so that I can start.
Yes, ma'am. Just give me a second. Yes, ma'am. We are now live.
A very good evening and a happy new year to all the esteemed faculty members and the delegates who have joined us today for the 216th Happy Learning Series webinar with the Andhra Pradesh Societies of Anantapuram, Bhimavaram, Chittur, Kadapa, Kurnool, Nandyal, Ongole, and Tirupati. We are very delighted that we are addressing a very important topic today. In our webinar today is obesity and management and the PCPNDT law, which will be taken as a reverse panel by Dr. MC Patel, sir. The program director and the convener of the series is Dr. none other than Dr. MC Patel, sir. We move forward with the webinar with the blessings of Lord Almighty. Can we have the inauguration slide, please? Nilesh, the inauguration slide, please. Slide number 5. Thank you. It is my proud privilege to introduce Dr. MC Patel, sir, as the program director of this series. Sir has been the past vice president of FOXY. Sir is an important medical legal counselor across India. Sir has been the past chairperson of the Ethics and the Medical Legal Committee in FOXY, as well as the organizing secretaries of AICOG 2017. He has also been the honorary state secretary of the SOGO from 2022 to 25. Sir is an active Rotarian as well as an active member in IMA Ahmedabad. Sir, we welcome you and request you to please welcome this gathering today.
Thank you, Dr. Monica, for kind words. It gives me immense pleasure to welcome you all to one more webinar from Happy Learning Masterclass web series. And today's joining society, as mentioned prior, Anantapuramu, Bhimavaram, Chittur, Kadapa, Kurnool, Nandyal, Ongole, and Tirupati. I welcome Dr. Sesasai Tirupati, sir. He has kindly consented to be chief guest to bless this webinar. Of course, he is always with me in any of my academic activity. Whenever I have called him, he is always there to guide me, support me, help me. So welcome, Sesasai, sir, and thank you for sparing time for this webinar. I also welcome Dr. Parthasarathi Reddy, sir, from Tirupati. He has kindly consented to be guest of honor. He is also always with us in any of our academic activity. Welcome, sir. I also welcome Dr. Padmalata Madam from Kadapa, and she has also kindly consented to be guest of honor to bless the webinar. And Dr. Aruna Rao Madam from Ongole, she has also kindly consented to be guest of honor to bless the webinar. I also welcome uh, Radha Lakshmi. She is master of ceremony today, and she is instrumental for this webinar, not only for designing this webinar, but execution of this webinar. And thank you, Radha, for all the efforts you put to make this possible. Thank you for the same. I also welcome all the learned chairperson, Dr. P. Padmaja from Nandyal, Dr. Venkataraman from Kurnool, Dr. Savitri Madam from Kurnool. They are going to chair very interesting session, obesity across the age, and it is to be delivered by learned speaker Dr. Uma Devi Madam from Kurnool. I also welcome one more set of chairpersons, Dr. Pramoda Madam from Kadapa, Dr. Tamara Devi from Kurnool, and Dr. V. Nagmani Madam from Nandyal. They are going to chair one interesting session, obesity during pregnancy, and it is delivered by Dr. Sri Devi. I also welcome one more set of chairperson, Dr. Usha Rani Madam from Kadapa, Dr. Manikya Rao from Kurnool, and Dr. Sarda Madam from Chittur. And they are going to chair very interesting session, and it is to be delivered by Sujay Sri from Bhimavaram. I also welcome all the learned panelists who are going to bombard question to me, as I am going to moderate this panel, and it is reverse panel. And today we are going to discuss PCPNDTX and its implication in our day-to-day OBGYN practice. So I welcome all the learned panelists, Dr. Sudharani Madam from Kurnool, Dr. Gayatri Madam, Dr. Suchitra Madam, Dr. Nagjyoti Madam, Dr. Bibi Salini Madam, Dr. Uma Devi Ralla Madam from Tirupati, Dr. Anita Sri Madam, Dr. Divya Teja Madam, Dr. Ramkrishna Hanuman from Ongole, Dr. G. Sudharani Madam from Kurnool, and Dr. Gayatri Ingla Madam from Kurnool. I also welcome my team, Dr. Monica Umardan, she is convener for this series, and all the coordinators, Dr. Monica Gupta, Dr. Nivedita Datta, Dr. Deepika Logani, Dr. Satabdi, and Dr. Megha Kamlapurkar, and all the president and secretary of Joining Society, and all the delegates who have joined this webinar. When I started this webinar in era of COVID, my aim was to meet our Foxian friends on screen and to say hello to everybody. But this series has become popular, and it was demand from all the delegates, and we have continued this series, and we are running this series with support of all the delegates, faculties, and others seniors with their blessings also. So as far as this series is concerned, we are discussing focus topic, and our ultimate goal is to check maternal mortality, because by 2030, WHO and central government has given us a target to check MMR below 70. It should be less than 67. Of course, there are a few states in southern India, they have a mortality rate near 30. But at the same time, there are few states in northern India, and particularly northern eastern India, they are still having maternal mortality near 200. And it's a matter of worry as an obstetrician for us. And that is why we should be very careful in dealing with any obstetric case, particularly when we are dealing with high-risk pregnancy cases. So early detection, in-time transfer, and institutional delivery could be a secret of success. And by 2030, we can achieve that goal. So with this mission, we are running this series. So welcoming you all. Thank you. Thank you very much.
Thank you so much, sir, for the welcome. I would now request Dr. Radha Lakshmi Madam to please introduce Dr. Sheshashayi sir from Tirupati as our chief guest.
Sir, good evening all. So it is my proud privilege to introduce Sheshashayi sir. He is a teacher of teachers. He did his MBBS from SV Medical College, Tirupati, and MD from Armed Forces Medical College, Pune, PG Diploma in Human Rights, SV University, Tirupati, worked in Army as captain for 5 years, NSS Program Officer for SV Medical College, Tirupati. And he worked as in various positions in SVMC Tirupati. Later, after his retirement, he is working in Chittoor Apollo Medical College as a professor and head of the department. He is a Lion Club's member, Secretary, Biostat Club, Tirupati, Family Planning Commissioner, AP Government, and recognized AP Government recognized laparoscopic surgeon, and recognized teacher for laparoscopic training center at GMH Tirupati. His hobbies being teacher, fencing game, diving, and technical analysis of NSC. And moreover, he is the sir is the running a examiners group with more than 3,000, sir. I'm correct, sir? Sheshai, sir? More than 3,000 teachers in his WhatsApp group and helping each and everyone regarding the teaching material, not only for the practitioners, but also for the teachers. He is very much useful. Thank you very much, sir, for being the chief guest in this webinar, sir. Thank you. Sir, you are muted, sir. Sheshai, sir.
Thank you, ma'am. Good evening to all. I'm very happy to see all of you, and it is one of the best scenario I'm enjoying by seeing everyone here. And today I was telling to our postgraduates, if you are attending all webinars, then it is more than you can secure first class or university first also. So it is such a nice way everyone is teaching in webinars, in Ops Gain especially. And in examiners group, we are having 3,000, almost every college professors in India and Andaman, Nicobar and other islands also, they are participating. In 20 countries also, they are participating. So it is really a service to mankind, and we are happy to see everyone. Thank you very much.
Thank you, sir. Thank you for sparing time for us to bless this webinar. Thank you, sir.
Thank you, sir.
Thank you, sir. It is always a pleasure to share the stage with you, right from the public awareness to all the happy learning series that we have done till now. Thank you so much for being there with us today. I request Dr. Monica Gupta, madam, to please introduce our guest of honor for today.
Thank you, MC Patel sir and Monica Umardan, for giving me this opportunity to be a part of this prestigious webinar series. I think none other than ours is such a long webinar series which we are putting a consistent effort every week to join every part of the corner of the India into our webinar, into our learning series. Today, it's my honor to introduce a guest of honor, Dr. G. Prathasarthi Reddy sir. He's a superintendent of Government Maternity Hospital, Tirupati. He's from the Holy Land of Tirupati with the blessings of Lord Tirupati. And he's a professor, Department of OBGY, SV Medical College, Tirupati, Andhra Pradesh, organizing secretary of APCOG and president Tirupati OBGY Society. He has got many research paper and publication to his accolades. He has achieved Dhira Award from Foxy in 2022, Vidya Ratna from Suman Art Theatre, Hyderabad, Pranantha Award from Abhiyan Arts, and Best Doctor Award from Tirupati City Chamber. Over to you, sir, for all your blessings.
I think sir is not there.
Acha, sir is not there.
Yeah.
No,
So
no
we
issue.
will-
When he,
we will take his
have blessings
blessing.
when he
Yeah.
joins.
When he will join, the next guest of honor is, please, there's a line. Dr. Padmalata ma'am. She's from Kadapa Society, president of society from 17 to 24, president of IMA Produttar, president of APOG, and president of AP chapter of ISAR from 2024 to 26, director of Mathurva Fertility Center located at Tirupati, Nellore, Nandayal, and director of Akshaya Hospital and Sri Balaji Hospital. Over to you, madam. And she has got RCOG publication in the RCOG General on the impact of personalized embryo transfer based on endometrial receptivity assay on pregnancy outcome in women with recurrent implantation failure, a retrospective study. Over to you, madam, for your blessings.
In a short while, she will be joining in a short while.
Next,
Link పంపించారు.
please put.
Okay.
Nilesh, there is a problem with your internet connection today. The slides are not clearly visible.
There's some. I can see the name.
Dr.
Please-
Aruna
please-
Kumari, madam.
Dr. Aruna Kumari, madam, she is a senior gynecologist and she is from Esther Ramesh Nolarai Hospital Nursing Home, and she's a president of Ongole. She's a senior teacher with a teaching experience and work experience for more than 30 to 40 years. Over to you, madam, for your blessings. I think madam has also not joined.
Hello, ma'am. Ma'am, I am the secretary, ma'am. Madam is having some work, ma'am.
Okay,
Ma'am,
okay.
Yes,
Ah.
ma'am.
No
Sridevi,
issue.
Sridevi.
Whenever they join,
Sridevi.
we have blessings from them at
Yes,
that
sir.
time.
Definitely, sir. Thank you, sir.
Yes, we can proceed further accordingly.
Now we can proceed to our academic session.
Yeah.
Over to you, Deepika.
So, good evening to all. And at the outset, thank you, Dr. MC Patel, sir, and Dr. Monica Omardan for giving me this opportunity. And without any further delay, we'll start with our first scientific session.
Yeah.
And can
One
we-
minute.
Yes, ma'am. Yes, ma'am.
Padmalata joined.
Okay.
Yeah. Padmalata, she is previously the president of Kadapa OBG Society. Now she is the president of Praduttur OBG Society. She is a very great influencer in AP regarding Foxy. I request a few words from Padmalata. Padmalata, you are muted. You are muted, Padmalata.
Ma'am, please
You need to
unmute
unmute
yourself.
yourself.
Unmute, Padmalata.
Ma'am, thank you for your kind words, Radha Lakshmi ma'am. I'm your student also, madam. You didn't tell me that point. Yeah, ma'am.
yeah.
I'm very happy for joining me in this webinar, ma'am. Thank you so much.
Thank you, madam.
For your blessings.
Thank you, madam, for sparing time for
Sir,
us.
sir, thank you so much, sir. I couldn't receive your call. Thank you so much, sir. Sorry for the inconvenience, sir.
It was simply for reminder for today's webinar.
Yeah, sir.
Thank you, madam. Welcome.
Thank you, sir.
Sir, there are many students in the webinar of me.
Ma'am, you are a great teacher.
Thank you.
So,
Yeah.
can Dr. Radha, ma'am, can we
Oh,
go?
yeah.
the start?
Yes, we can
Yes.
go further.
Yeah, so Nilesh ji, can you start yes. So I will be introducing the chairpersons for the session 1, and it's my privilege to introduce our first chairperson for this session, Dr. Padmaja P. Padmaja ma'am. Ma'am is the professor and head of Department of Obs and Gynae at Government Medical College at Nandyal with over 20 years of teaching experience. Ma'am has numerous publications in journals and is an active participant in state and national conferences, and her area of special interest is infertility. Dr. Padmaja is widely respected for her academic contributions and dedication to teaching. And ma'am, we are honored to have you chair this first session. Can we have the next? Yes. So our next esteemed chairperson is Dr. S. Venkata Ramana sir. Sir has over 25 years of service at Kurnool Medical College, from where he retired as the head of Department of Obs and Gynae. Sir is currently working as Professor of Obs and Gynae at Vishwa Bharati Medical College, Kurnool. Sir is a trained advanced laparoscopic surgeon and is the president of the Kurnool Obs and Gynae Society, and is also a member of the Safe Motherhood Committee of Foxy. So we are so happy to have you with us as chairperson for this session. Can we have the next CV, please? And our next chairperson for the first session is Dr. Savitri Sudhakar ma'am. Ma'am is the professor and head of Department of Obstetrics and Gynae at Kurnool Medical College, Kurnool. She's a senior undergraduate and postgraduate teacher and examiner with areas of special interest in high-risk pregnancy and infertility. Ma'am, we are very happy to have you chair this session.
Thank you, ma'am.
Can we request our chairpersons to introduce our first speaker for the session, and who is none other than Dr. M. Uma Devi ma'am, and ma'am will be speaking on obesity across the ages of women's life. Can we ask one of our chairpersons to please introduce Dr. Uma Devi ma'am?
Dr. Uma Devi is working as associate professor at Kurnool Medical College, and she is a UG PG also from Kurnool Medical College. And she has more than 16 years of teaching experience. She is trained in medical education by Harvard T program, participated as speaker in CMEs and state conferences. She is a very dynamic person, 26 years of dedicated public sector service, areas of interest, high risk pregnancy and preventive oncology. Over to you, Uma, and all the best.
Savitri, your video is not visible.
Yeah.
Ma'am, you can start, Dr. Uma ma'am.
Yes. Thank you for the kind words. At the outset, I would like to thank all my teachers who are there in this group, great teachers, Radha Lakshmi Madam, Savitri Madam, Padmaja Madam, and Venkatramana Sir, and MC Patel Sir for giving me this opportunity in such a big platform. Corona used to be the big black platform for our learning. Let us take it as a happy learning. And at the outset, I am thanking everyone for giving me this opportunity. So today's topic is obesity across the ages. It is not only across the ages, but also across the world and across the globe. It's more commonly seen in women. The scope of this session goes like this with the definition, basics, pathophysiology, impact of obesity among the women, and what are all the factors, what are all the reproductive and postmenopausal problems that we encounter, and what are all the measures to control obesity and for weight loss. We need to consider obesity as a pandemic. It is a global health hazard. It is the single greatest threat to the public health in this century. Obesity is mainly a neurohormonal metabolic disease. The unique feature being excess or abnormally distributed adipose tissue. And it is a result of complex genetic environmental factors leading to dysregulation of the energy homeostasis, affecting mainly satiety and central neuroregulation. And in common words, it is excess accumulation of the adipose tissue. When we see the prevalence, there is a static rise in the prevalence of obesity among the Asian countries from 2015 to 2021, according to the census. Almost 3 out of 4 Indians are overweight. When we look upon this, the maximum risk of age being seen between 28 to 38 years, where both the men and women of these generations, they are getting settled in their professions and getting relaxed, and they are taking whatever they want to do. That might be the one reason. Almost 50% of the urban Indians are obese and 73% of the urban Indians are overweight. This is an alarming indication. Obesity is rapidly growing amongst the middle-aged women in India. If you see this slide, in the women from 40 to 49, the incidence been shown, but as the age increases, when it comes to the middle age, it's going to be more. There is a rapid increase according to the NFHS survey. The prevalence of obesity is alarming. In India, urban prevalence of obesity has increased alarmingly, accounting for 50% of the adult urban Indians, and 29% of the children are either overweight or obese. 5% of population of India are morbidly obese. 15% of women are obese. This more commonly nowadays being seen in younger women. The child of a normal weight has a 10% chance of developing obesity in future. And if both the parents are obese, you look at the figures, 80% of the chances. Nowadays, the younger generations are more obese, overweight. Look at the future generations, according to the 80% chances of being obese next generations. Why we are worried? Because of the mortality and morbidity. Mortality due to the diabetes, hypertension, coronary artery disease, and CVA at an younger age in obese women than the normal one. And also morbidity for the so many medical conditions which are well known to us. These are all the medical complications of obesity. We are all aware since ages, from head to toe, every organ, every system is being affected by obesity. The reasons we all are aware: because of the stored and processed high caloric food, increased economy in the nuclear families, lack of leisure in the working women, and availability of the gadgets from the time they are born till the even now the grandmoms are also learning how to use smartphones and all, and sedentary lifestyles. Of all these, unhealthy dietary habits and sedentary lifestyle are mainstay of reasons for increasing obesity. I think who can read this Telugu can understand this. And we have seen such a change over the time. Whenever we were children, we used to see such kind of scenarios in our villages, in our neighborhood and all. Nowadays, no one is being seen doing a physical activity. Though the women have been empowered with education, technology, globalization, and everything. So that is one of the reason that has given, these are the social factors which can give rise to increased obesity among the women in all the age groups. When coming to this, I don't need to explain about the junk food. Coming to the proper, what is obesity? It is storage of excess fat in the body due to imbalance between the calorie intake and expenditure. It is caused by long-term positive energy balance. So whatever, how many calories we eat and how many calories we spend, there should be a balance to maintain a healthy lifestyle. But obesity results from long-term positive energy balance. That is, the calorie intake is more and the calorie expenditure is less. When it occurs over a long period of time, it results in obesity. It is prevalent in women when compared to men. Why? Because of the comparatively low basal metabolic rate in women. And when it comes to the postmenopausal women, it is still more because of the absence of ovulation and absence of progesterone. As the age increases in women, the BMR decreases. After the age of 18 years, there will be 2% decrease of BMR. After the age of 30 years, weight gain will be inevitable unless there is an increase in the physical activity or decrease in the calorie intake. So one has to take care of their weight as early as 30 years. After the menopause, due to the loss of luteal effect, it leads to extra amount of weight gain. So how to assess obesity? These are all the parameters: body mass index, waist to hip ratio, waist circumference, tricep skin fold thickness, especially in children. The ideal method is hydrodensitometry. So how to classify this? There are so many things. One is according to the body mass index. The other one is depending on the fat distribution or anatomical obesity, and according to the cell type. Coming to the body mass index, we all know that we calculate BMI. Nowadays, everyone is able to have a smartphones. If you tell them calculate your BMI, so that they'll come to know whether they fall in a normal range or obese or overweight. Current guidelines for overweight and obesity based on BMI is, according to WHO and CDC, BMI more than 25 or more is overweight, over 30 or more is obese. According to International Diabetic Federation, accepted cutoff values for Indians are more than 25 BMI. That is obesity. More than, I think it is 23 is overweight. We need to calculate it by weight in kgs by height in meter square. WHO classification gives a normal BMI falls between 18.5 to 24.9. Overweight is 25 to 29.9. And class 1, class 2, class 3 obesities, that is beyond 30 to 34.9, 35 to 39.9, 40 or more. According to fat distribution, android type of obesity, otherwise called as visceral obesity, there is a male type or masculine type. The other one is gynoid or pear-shaped obesity. If you look at this, the central obesity is mainly seen in apple-shaped obesity. Pear-shaped obesity is seen in gluteal region. So anatomic obesity, when we see it, gynoid obesity is a pear-shaped obesity. The fat is mainly deposited in the femoral and gluteal regions. This type of adipose tissue is resistant to catecholamines and it is sensitive to insulin. Extraction or storage of fatty acids is easy. It has a negative effect on the fatty acid metabolism is less. So the risk of developing complications, gynecological, obstetric or metabolic complications in this type of obesity is less. Android obesity, it is apple shaped or central obesity. Abdominal visceral fat distribution will be more. This type of obesity, the adipose tissue will be sensitive to catecholamines, but it is less sensitive to the insulin, which is the only anabolic hormone in our body. This is associated with hyperinsulinemia, impaired glucose tolerance, thereby leading to diabetes, increased androgen levels and decreased SSBG. All these will give to the risk of developing metabolic syndrome, but which is reversible with weight loss. According to the cell type, we know there is hyperplastic and hypertrophic. Type A is enlargement of the fat cells, which is hypertrophic type of. So this type of obesity is usually of adult onset obesity and is strictly hypertrophic. All obese individuals experience hypertrophy, but not all have an abnormal amount of fat cells. The other one, B type, is increase in the cell number. This type of obesity, the onset is juvenile onset because the development of extra fat cells occurs mainly during the early or late childhood. Once hyperplastic obesity has been developed, weight can be lost from the fat cells, but already there are more number of fat cells, so the risk will be more. That is, the first is the BMI to assess. The other important clinical parameter is a waist to hip ratio. Here we will measure the waist circumference at the level just underneath your lower rib and the hip at the widest portion of your buttocks, and divide these two will give you a waist to hip ratio. In women, if you see, it is low is 0.8 is low or normal, 0.8 to 8.5 is moderate, and more than 8 is high. So they are high risk or they are overweight or obese. Waist circumference, this is another parameter where you can assess the obesity. It's the best predictor of central obesity, just to be measured above the level of the hip bones at the end of the respiration. Waist circumference of more than 40 inches or 1 or 2 centimeters in women, or more than 35 inches or more than 88 centimeters in women are predictive of metabolic or endocrine abnormality. The risk increases at a threshold of 94 centimeters for men and 80 centimeters for women. So a little bit of basics. There will be an equilibrium between lipogenesis and lipolysis. This takes place mainly in the adipocyte. Adipose tissue mainly serves three purposes. It is a powerhouse of energy, thermoregulation, and it acts as a cushion, especially for the retroperitoneal organs, and prevents trauma. The basic physiology, where whenever the glucose is abundant and in the presence of insulin, this will be converted into G6-phosphate and triglycerides are produced. When the energy sources are less, again the triglycerides will be converted back and intracellular free fatty acids are produced and they can be released into the circulation. In this process, the heat will be generated, thereby maintaining the energy balance. When glucose is abundant, the free fatty acids are produced and they enter into the adipocyte when glucose is in abundant situations. When it is depleted, the reverse mechanism will take place. The triglycerides will be released from the fatty tissue and serves the glucose for other tissues. The adipose tissue is mainly stimulated by catecholamines like epinephrine, norepinephrine, ACTH, TSH, growth hormone, cortisol, glucagon, and HPL. It's inhibited by insulin. The adipocytes lipolysis will be stimulated and release of free fatty acids. That is, conversion of energy and energy expenditure is mainly done by exercise, whenever you are nervous, and by fasting, and during exposure to cold. So endocrinology of adipocyte is an emerging topic. There are a lot of studies regarding the pathophysiology and endocrinology of adipose tissue in the recent years. It has been found that leptin, adiponectin, and I think one more this thing is that is been wrongly printed here. These are the three endocrine products that have been exclusively produced by the adipocyte. They regulate food intake, reproductive axis, and insulin sensitivity and immune response. They play a very important role in all these mechanisms. Through all these mechanisms, it's going to affect various functions of the body. Leptin, we all know that it is a protein amino acid. It is a Greek word. It is secreted from the adipose tissue. It circulates in the blood in a protein bound form. It acts on the CNS neurons that regulate eating behavior and energy balance. Circulating leptin levels are in proportional with the adiposity. The obese individuals have more levels or higher concentrations of leptin. It serves as an endocrinal signal for caloric status. It plays a major role or acts as a signal to the satiety center in the hypothalamus, and they regulates dietary intake and fat storage. Obese people are not leptin resistant, but rather some people are leptin resistant. Thus, they have a high or elevated levels of leptins. So in the fasting state, whenever we eat, the glucose levels will be increased, the insulin will be released from the pancreas, and along with that, the fat cells will secrete more amount of leptin. They act on the central nervous system and decreases the NPY and increase melanocortin and causes satiety. The opposite happens whenever you are in a fasting state. The insulin will decrease, the adipocyte they don't release any leptin, the leptin levels will form, and again it leads to send signals to the hypothalamus and causes eating whenever you are on fasting. The role is leptin has an ability to reflect in energy balance that suggests that it may serve as a link between the nutritional status and reproduction. Leptin participate in timing of the puberty, both in under and overnutrition people. Leptin administration has been observed to accelerate the onset of puberty in humans and also in rodents. The another important thing that is ghrelin. It is an amino acid peptide secreted by the stomach, ovary, testis, and placenta. These leptin and ghrelin have an opposite actions to balance between the energy expenditure and conservation of energy. Ghrelin and leptin have opposing actions. Ghrelin is a signal to conserve energy by increasing appetite. Leptin is a signal to expenditure of the energy. A connection between the reproduction and the body's state of energy metabolism is now well established, concentrating around the complex between the leptin and ghrelin system. So there are so many cytokines have been involved. That is interleukin 6, 8, CRP, TNF alpha are all elevated in obese individuals. Why we are discussing about this is IL-6 and TNF alpha are secreted by the adipose tissue. Raised TNF value, what they cause, they impair the follicular maturation and they have a role in the insulin resistance. When it comes to the CRP, raised CRP levels have been observed in obese individuals, and it's an independent risk factor for insulin resistant and hyperinsulinemia. All these will put together as a vicious circle. They contribute to the infertility in obese individuals. So coming to the endocrinology, the basal levels of insulin will be elevated due to the downregulation of the insulin receptors that leads to metabolic syndrome. Metabolic changes are reversible with a weight loss of at least 5 to 10%. This we need to remember that suppose if a person is morbidly or class 2 or class 3 obese, they need not lose at a time to a normal level of BMI for them, but with a minimal decrease like 5 to 10% of the weight loss can yield a promising results for them. So how to identify this is the glucose hyperinsulinemia or glucose intolerance. We need to go for a 75-gram glucose tolerance test is a method of choice to identify the insulin resistance like a general population and also in obese people. Fasting to postprandial insulin ratio is not recommended as the levels vary. Because of the insulin resistance, there will be changes in the there occurs increase in the circulating free fatty acids, decrease in the catabolism of triglycerides. Overall effect will be like a decrease in HDL and increase in LDL. That leads to metabolic syndrome. The parameters that we need to consider is whenever you look at the hypertension, it should be more than 139/85, triglycerides of more than 150 milligram per deciliter, HDL less than 50 milligram per deciliter, and waist circumference of more than 35 inches. Fasting glucose is 110 milligram per deciliter. When all these parameters, it's easy to do all these things and to identify early the developing of metabolic syndrome in overweight and obese individuals. So how to interpret the 75-gram glucose insulin glucose tolerance test. So the normal levels of fasting glucose will be, all we know that is less than 100, after 30 to 90 minutes less than 200, and after 120 minutes it is less than 140. So the interpretation would be, if you have a more than 100 or more than 20 milliunits of insulin, impaired fasting glucose will be between 100 to 125. There you need to alert. Diabetes, if it is more than 126, the fasting glucose levels, and insulin resistance, if it is more than 20 of fasting insulin levels are there, it gives rise to insulin resistance. After 90 minutes, insulin levels must be 80 to 100. It peaks at 30 minutes, decline over a period and remains between 80 to 100. Insulin resistance is being diagnosed whenever the insulin levels have between 80 to 100, and severe insulin resistance when the levels are more than 30. After like 2 hours, we all know that glucose levels 140 by 2 to 200, and diabetes is more than 200. Insulin resistance, if the levels of insulin after 2 hours of injection of 75 grams of glucose, if it is 55, and severe insulin resistance is more than 100. So coming to the topic proper, these are all the basics, the metabolic changes that what we take place in any of the age groups. So I wanted to just make a few points about the basics. So obesity across the ages, it can affect the pubertal, prepubertal, reproductive, pre and postmenopausal age groups. Juvenile obesity is associated with early menarche. Peripubertal and prepubertal onset of obesity leads to menstrual irregularities. Day in, day out, we are seeing like a PCOS picture with all full-blown obese young girls coming to the OPDs with amenorrhea and irregular cycles, and amenorrhea followed by menorrhagia, oligomenorrhea. All this happens with the central effect of affecting the HPO axis. Hyperinsulinemia, hyperandrogenemia because of the peripheral conversion of estrone will be there, leading to peripubertal ovulatory dysfunction. That is the main cause. And androgen status tracks from the childhood to the adulthood and is directly related to its fertility. So whoever is having a juvenile obesity, in the future life, they will also become obese and face all these problems. 50 to 70% of the obese children will remain as obese adults. Elevated BMI at the age of as early as 80 is a risk factor for subsequent ovulatory infertility with or without a diagnosis of PCOS. Keeping aside the PCOS, obesity itself is can cause ovulatory infertility. So obese women, the marked features will be like in a reproductive age group, they can have hyperinsulinemia, insulin resistance, relative hyperglycemia, lower serum sex hormone binding globulin levels that leads to higher level of total or free androstenone, testosterone and DHEAS, decreased GH pulse amplitude, increased LH pulse frequency, attenuated LH pulse amplitude. All these will lead to anovulatory dysfunction and also infertility. So coming to the IVF. So all these women, they'll go for an IVF. The success rate in IVFs will also depend on how obese you are and what is your BMI. IVF pregnancy rates, success rates are lower in obese women when compared to the other people. It's one of the things that are related are because of the higher percentage of immature eggs in case of obese women. It is an independent risk factor for early pregnancy losses even after IVF or ICSI due to the less number of oocytes in this obese individuals. So once you lose some amount of weight, that leads to decrease in the free testosterone level and increase in SHBG levels have been reported with a weight loss of as small as 5% of your initial weight. The androgen levels will decrease. So that will have a fruitful effect in the one's infertility profile. A 7 to 10% of reduction in body weight effectively restores the fertility by spontaneous ovulation and increasing the sensitivity of ovulation drugs when you go for infertility management. So we need to counsel. So if you want to conceive, lose weight. So preconceptionally, one has to plan. First thing is counseling plays an important role. You have to screen for all the metabolic syndrome, lipid profile and all. When one such lady comes to with infertility, weight loss is the key role. and OGTT has to be done, and metabolic syndrome profile has to be done. Folic acid supplementation has to be done in all obese women 3 months prior to the conception, and correction of vitamin deficiency, if it is there, also plays an important role. Coming to the contraception, CVOCs are contraindicated due to its metabolic effects. They interfere with the pharmacokinetics of OC pills, obesity. The effectiveness and safety will be decreased in obese women when it comes to OCPs. The estrogen component of the OC pills, they have a risk of vascular thromboembolic episodes, which is already a risk factor for obese women. The recommended methods of contraception are IUCDs or progesterone-containing contraceptive methods of any route. After bariatric surgery also, effective contraception is to be advised for 1 year. The laparoscopic sterilization is associated with no risks in case of obese women. Obesity and vitamin D. Obese individuals are often found to have low levels of vitamin D because it's being fat soluble. Vitamin gets de-sequestrated in the adipose tissue. So overweight and obese individuals need higher dose of vitamin D for their replenishment. Weight loss will improve the vitamin D levels in obese women. Coming to the reproductive age group, they can present with abnormal uterine bleeding. It can lead to polyps because of the hyperestrogenic state and adenomyosis. We know that the leiomyoma and malignancies. So all the like structural lesions that can be attributed to the AUB and ovulatory dysfunction, endometrial dysfunction, most of the almost 80 to 90% of these AUB causes are related to the obesity and the hormone profile. That can lead to endometrial polyps, and fibroids will also become more increased in size and symptomatic when in obese individuals when compared to the normal people. This mainly due to the peripheral conversion of androgen to estrone and decreased SHBG. All this will give you an environment of hyperestrogenic state where they will cause proliferation of the endometrium, and it can turn into either adenomyosis or polyp or fibroid or anything. So coming to the perimenopausal or urinary problems in obese women, obesity of all types are associated with stress urinary incontinence. Mainly the visceral obesity, that is the central obesity, is associated with increased abdominal pressure. Resting abdominal pressure will be more. So added to that, pressure on the pelvic floor muscles and lack of estrogen in the peri and postmenopausal women, they add aggravating factors. In obese individuals, the resting intravesical pressure is more and it exerts more power during the coughing that can lead to stress urinary incontinence. This happens even in the presence of a normal urethral or continent system. Obesity is a strong independent risk factor for urinary incontinence in adults. There is a dose response effect in obese women. Each 5-unit increase in BMI is associated with 20 to 70% increase in urinary incontinence risk. Menopausal therapy. Whenever we plan a menopausal therapy for hot flushes, like things, so the caution has to be taken whenever you go for a menopausal hormone therapy. It has to be individualized, taking into account of the individual risk factors for thromboembolism, carcinomas, everything you need to screen and go for menopausal hormone therapy. There will be risk of vascular thromboembolism and serious complications are to be assessed before going for a hormonal therapy in obese ladies. Breast examination and annual breast mammography is mandatory in obese women, and it's a universal actually, but risk of breast cancer has to be evaluated prior to going for any hormonal replacement therapy in obese individuals. For minor symptoms, transdermal patches of low dose estrogen are preferable than the oral forms. Choice of therapy depends on the severity of the symptoms and individual risk factors. The risk of fractures in the postmenopausal women. So this is a FRAX scoring system where the components will be like age, gender, weight, and height. So this FRAX score will give you a 10-year probability of fracture in untreated patients. So whenever we put a scoring system, this is a WHO fracture scoring system. It's a tool, we call it as FRAX scoring. So one of the main component is weight. So automatically the risk of fractures in postmenopausal women over a 10-year period will be increased in obese and overweight people, are more risk of developing fractures due to the osteopenia. Coming to the pelvic organ prolapse, it's obesity is aggravating factor. It's not a direct effect, but there will be increase in the intra-abdominal pressure that can lead to aggravation of the symptoms in obese individuals with prolapse than the controls. Obesity is linked as a cause of morbidity, cancer in 20% of cancer deaths in 20% of women. So let us see risk of developing malignancies in the increases with menopause. Almost like 13 cancers are related to the obesity in menopause. It's mainly due to the long-standing inflammation and insulin resistance, and insulin-like growth factor, sex hormones are mainly implicated in the pathophysiology of cancers in the obese individuals. The risk increases with the duration of overweight and amount of excess. So the more the duration, more obese, the risk of all these cancers will increase in the menopausal age group. Suppose they may be normal, they don't have any metabolic problems, but in the later life, there is always risk. So obese menopausal women also have to undergo periodic screening for various cancers. The numerous cancers associated are esophageal, pancreatic, colorectal, postmenopausal breast carcinoma, and endometrial carcinoma. The mechanisms involved are mainly induction of inflammation. The chronic inflammation is nowadays being considered as an important risk factor for various pathologies, and turning on of the oncogenes and hyperinsulinemia and estrogens play an important role in cancers. The incidence of cancers related obesity or breast cancer. Increased circulating level is a risk factor for the development of postmenopausal breast cancers. SERMs have been shown to decrease the development of breast cancers in these ladies. Next is the endometrial adenocarcinoma. It's mainly due to the increased unopposed action of estrogens. It increases with endometrial hyperplasia. Approximately 25% of complex atypical hyperplasia becomes invasive adenocarcinoma. The most prevalent form of endometrial carcinoma is adenocarcinoma, and the risk increases with endometrial hyperplasia. The risk of endometrial adenocarcinoma in obesity is 3.5 times more than the normals. In UG days, we have learned corpus cancer syndrome, where we considered obesity, diabetes, hypertension as a risk factor for endometrial carcinoma. The ovarian cancers. There is a twofold increase in the risk of obese older women who never have taken any postmenopausal therapy. In spite, they are developing ovarian carcinoma. Other things are esophageal carcinoma and colon carcinoma. So as a nutshell, what we daily face because of the obesity is menstrual irregularities, PCOS, infertility, diabetes, ovarian, breast, and endometrial carcinoma as a gynecologist. So whatever may be the age, whatever may be the problem, definitely as a obstetricians and gynecologist, we may have to go for surgeries. So this is the challenge for the anesthetists. So picking up of veins and giving, because of the lumbar curve, the structural changes, impalpable iliac crest, impalpable vertebral spines, the anesthesia is definitely a challenge for anesthetist. During surgeries, we face, so if there is a 150 kg or 100 kg woman is there posted for surgery tomorrow, the entire previous night we'll be planning how to do. There will be entry, what type of incision, how to close the incision, what are all the suture materials. In obese individuals, we need extra assistants, senior persons, difficulty in closure, wound infection in the postoperative period, prolonged hospital stay, postoperative complications in the form of either pulmonary atelectasis, antibiotics, and risk of DVT. This has to be kept in mind whenever you are doing a small surgery for an obese woman, even a cesarean section, after the obese individual with diabetes or hypertension or preeclampsia, you have to be very careful. Surgical choice for gynecological procedures, ideally laparoscopy or minimal access surgery is preferred over an open methods, and TLH is preferred over a vaginal route for pelvic organ prolapse according to recent articles. For morbidly obese patients, ideally, if the surgeon is skillful, robotic assisted minimal access surgery is the ideal, where a morbidly like class 4 or class 3 obese persons, there is no choice to go for a surgery. Then robotic assisted, which is in the rising trend nowadays, it is an ideal surgical choice. A few points regarding the surgical technique when you are operating. structures like retroperitoneal ureters. Usually we will be fear of ureter whenever you do in a gynecological surgery. The ureter ideally has to be dissected separately, as there will be a more amount of adipose tissue and these structures will be deeply embedded in the retroperitoneum. So you have to trace the ureter whenever you do any surgery in obese individuals. You have to skeletonize the vascular pedicles. That is also important, and then only you have to go for either ligation or coagulation. These are few practical points, and you can take the help of a vessel sealers that will decrease the blood loss when you are doing any surgery in obese individuals. Coming to the skin closures, it's always ideal to keep a subcutaneous drain. That's what we do. We are practicing in our hospitals nowadays to prevent third space collection, hematomas, wound infection, and wound gaping. The DVT prophylaxis, the regular dose in these individuals is inadequate, and higher doses and duration is required. Low molecular weight heparin, you have to calculate depending on the body weight, like 0.5 milligram per kg body weight. Unfractionated heparin, 7,500 units. Subcutaneous TAD has to be given. Fondaxaparin, 7.5 milligram daily. Usually, it has to be, the prophylaxis is ideal for a prolonged period in patients with more than BMI 40. The postoperative complications being many, one of it is an incisional area in the later life. So how to manage? So all this we learn, we tell the patient, go PCOS in infertility, lose weight, how to lose weight. So the plan should be slow and steady. Calorie restriction plays an important key role to reduce the weight. You need to give a plan to the patient like 2 to 3 kilos in the first month, 10 to 15 kilos in the next 4 to 5 months. So it appears more realistic and like a positive effect on the patients. You can encourage like that. Reducing the caloric intake by 500 to 1000 kilocalories per day will give you a good results. And there is one thing like unsupplemented protein preparations are available. They are dangerous as per the textbooks because of sudden deaths due to cardiac arrhythmias. You know, to lose 1 pound of fat, you need to burn 3,500 calories. So that is more scary. Be aware when you are eating something. But weight loss of as less as 5 to 10% will have a promising effect on decreasing the risk of metabolic risk. So keep this in mind. That gives you to lose weight in a more encouraging manner. The ideal diet, we all know that the carbohydrate should contain 50 to 60%, and of all this, these carbohydrates, complex sugars, we need to concentrate more, not on simple sugars. Proteins 15 to 20%, fat is less than 30%, mostly unsaturated fat. Exercise, it plays an important role along with the diet. How it helps? It by inhibition of appetite. If you observe, whenever you do some regular exercises, you don't feel like eating. And then by increasing the pulse rate and thereby increasing the metabolic rate, it helps to calories burn. The effect will be there, last for 2 to 48 hours. And the ideal way is 30 to 45 minutes of brisk walk a day for 4 to 5 days a week is ideal. Best time is before meal or 2 hours after eating, or otherwise daily you can do at least 1 hour of brisk walking. These are all the various physiological activities and calories burnt per hour. So whenever you are doing just office work, it is only 240. And comparatively, running slowly will burn 750 calories, and running fast is the highest one, that is 960 calories per hour you are going to burn. Among all these physical activities, if you observe, jumping, hopping, so I think whenever you involve with overweight, you have to keep of your care of your joints directly. And class 3, class 4 obese individuals cannot go for a jumping like this. Swimming is ideal, where you are going to lose 600 calories. And the ideal thing is, who cannot move can do and home cycling methods. They are all available in our houses, almost in every house. So these are all the things. But whenever all these fail, there is adjuvantive pharmacotherapies available. The drug treatment for the patients is indicated with when BMI is more than 27 with one medical comorbidity, then you can go for pharmacotherapy. If all committed lifestyle changes and caloric requirements have failed, but they are left with some comorbidities, you can as well go for a pharmacotherapy and surgery as a last resort, and all other modalities fail. And in patients with more than 40 or more than 35 to 40 with comorbidities, also you can advise to go for a surgery. These are all the areas where the anti-adipose, like anti-obesity drugs act, that is one in the hypothalamus, another drugs like the stomach, pancreas, and intestine by various methods. If you look at this, GLP-1 receptor agonist, they have a central action and also peripheral action in the gut. These are all the FDA approved anti-obesity drugs. They are phentermine, orlistat, all these, liraglutide, naltrexone, all combinations they are using, but under supervision only these anti-diabetic drugs have to be prescribed. They are contraindicated in pregnancy because of the hypersensitivity. Ozempic, nowadays, I don't know whether it is being available. In the last year, last December only, it has been launched in India for the treatment of type 2 diabetes as a weekly injection. It contains semaglutide, once weekly injection like that, but it also helps in reducing the weight loss. FDA approval in other countries is there for Ozempic prescription, but I think we are not getting, I don't know the real picture of in India because it has been recently launched. Weight loss surgeries are available. These are the various like bariatric surgeries like gastric sleeve plication, where some amount of the greater curvature of the stomach have been sleeved out, and this is the gastric sleeve, gastric bypass, and duodenal switch. All these, they will have their own plus and negative points. So only banding will be have a reversible. All other methods, the reversibility is not there. The weight loss is more with the bypass duodenal switch method, and also remission of diabetes has been seen in from 40 to 80% with all the above methods. The duration will depends on the skill, and hospital stay is because of the laparoscopic surgeons are doing in a better way. It is between, hospital stay is minimal. So it is also associated with, so nowhere you are free once you become obese or overweight. If you use drugs, they will have some complications. If you undergo surgery, they'll have their own complications like GERD, hiatus hernia, strictures, hemorrhage, and then leak. This will be like, and nutritional deficiencies. So November 26th is being considered as anti-obesity day. Consider as every day as an anti-obesity day. Those who wish to reduce their weight, take care of your body because it's the only place where you live. And epigenetics has been in the research field in case of obesity and weight loss. Newer diet programs, really, I don't have an idea. But think some weight loss procedures, they advise only fatty diet. So we need to think about it. Are we forcing ourselves to undergo constant gluconeogenesis? What are the long-term effects of at a cellular level? It has to be proven scientifically. The take-home message is the risk of obesity starts from the fetal life, and as maternal obesity also has place in the fetal life and in the future also. Adequate physical exercise, pre-conceptional weight loss, and a healthy lifestyle will give you benefits a long way from birth and later on. So decide whom you want to be. Thank you.
Requesting the chairpersons to please. Yes.
Madam, good evening, everybody. Just I had my student, Dr. Uma.
Sir.
Good evening, everyone. First, let me congratulate Dr. Uma for highlighting very well on this burning health issue that each and every age group people, not
Yeah.
only women, both men are facing.
Men and women should walk. Very nice presentation.
Hello. Uma, it was a very nice presentation, very informative, extensive. But I just wanted to add 2 points.
Yes, ma'am.
Insulin spike after every meal and intermittent fasting. So there is going to be an insulin spike after every meal. That is what the newer concepts. And intermittent fasting. Fasting for more than 14 hours. Only then the fat starts burning. That is the newer concept, which I heard in a recent one of the conferences. But to translate the knowledge for patient counseling is very difficult. The patients say it is because of thyroid or because of menstrual irregularity or because I'm not getting my menses. That is how. But intermittent fasting for more than 14 hours is what going to burn the fat cell. So first the visceral and then the parietal. So the immediately the shape of the body doesn't show, even though you are losing the visceral fat. That is what the concepts are now. And it was very nice and very extensive and informative. Thank you very much.
Thank you, Venkatramana sir, Padmaja madam, and Savitri madam for your inputs. And actually, people regarding intermittent fasting, they do fast for 10 hours and expect results. It's not like that, no, madam. They have to, people will be telling like an inch loss. That is, the visceral fat will reduce, not the total body weight. That's going to help us. But what I learned is losing. We are asking the patients to go lose weight and come back. So they won't hear. We have to give like a small targets, like 1 month, 1 kg, 2 months, 2 kg, like that. So it will be more practical, and we need to counsel them like that. It's going to help you to decrease your metabolic risk and your fertility. Usually we'll be seeing in PCOS and patients that's going to improve your like reproductive function also. So that's what I have learned.
And Ozempic is also available in India, and I have seen a man taking Ozempic injections, and he has lost that tune of more than 20 kgs in a matter of 3 to 4 months. So sometimes it is very difficult. The most difficult thing in the world is losing weight.
Yes, ma'am.
All know
yes, yes, ma'am. I think most of
Savitri, not losing the weight, but you should be sustainable.
Yes.
Once you lose the weight, again you will eat, you will get the weight rebounds.
Yes, sir.
So you should be sustainable. You have to maintain that weight loss.
Yes, sir. Yes, sir.
Gradual weight loss and sustenance is very, very important to prevent all these complications. And
Sir, I would think
whatever good results.
itself is difficult to achieve. Losing weight is first thing. That is the menace, first thing which we are going to hinder our process. So we get demotivated, not losing the weight. First thing. The same thing happens with the patient. That is what I feel. Okay, intermittent fasting more than 14 hours. All rituals of Hindus where they say you have to fast, do fasting.
Shivratri, Masa Shivratri.
Yes, madam. Just likewise, with all the like our old and traditional rituals, they have a scientific basis. Like doing a menarche function where they lose amount of blood loss, they need more amount of protein, they increase in size. Somebody giving you gifts, good food, and all that's going to help. Likewise, pregnancy. Like there is some scientific basis, but our ancestors has made a tradition without explaining to all the general population, so that everybody will follow, thinking that it's good for them.
So,
Thank you, madam, at the outset.
sorry to interrupt, Uma. Thank you for your presentation. There is a shortage of time.
Sorry,
I have our Nivedita Datta to introduce our second session chairpersons and the speaker. Nivedita.
Yeah. Good evening, everyone. And I think that was an excellent deliberation and a very interactive session. It led to a lot of talks and crosstalks, and I think we could just go on, and I loved hearing it. Thank you, Uma ma'am, for that excellent deliberation and all the faculties for the interactions. Moving on to the next session. The next session is obviously, since we have already discussed obesity in various age groups, the next session will be on management of obesity. And to chair this, management of obesity in pregnancy. And to chair this session, we have some excellent academicians. Could we have the CVs, please? Hello?
Yeah, Nilesh.
Could I have the CVs? Okay, fine. Let me.
दीदी ब्यूटी का टीचर को भेजिए ना। हाँ हाँ भेज दीजिए। हाँ बच्चा को नहीं चाहिए।
Hello?
मिला नहीं मिला।
Ma'am, just a moment. I'll.
Requesting everybody to please unmute themselves. And Nilesh, can you please share the CV slides for the next session?
I'll go through the compiled CV deck. It's okay. If he's taking some time, let me go through the CV deck. It's okay. No, not an issue. It's not an
Yes,
issue.
ma'am.
I'll just go through the CV deck. It's
Heartiest congratulations, Suma ma'am. It was a very well structured and a thoughtful talk which has covered almost all practical aspects on obesity and women's life.
Thank you,
okay,
ma'am.
the first chairperson in this series is Dr. Pramoda Reddy. Ma'am she is the secretary, Andhra Pradesh State is ISAR, the secretary Kadapa Obs and Gynae Society, and the executive council member of Yogi Vimana University, Kadapa. She's at present the director of Mathrusri IVF Clinic Kadapa, as well as the consultant in Suraksha Super Speciality Hospital Kadapa. Major areas of interest are in conducting live workshops, especially in hysteroscopy and ART. The next chairperson is a very eminent Dr. Tamara Veni. Ma'am, she is the professor and head of the department of Obs and Gynae at VB Medical College, Kurnool. The third chair in this session is Dr. V. Nagamani, a very senior gynecologist, president of Nandyal Obs and Gynae Society, and the managing director of Madhumani Nursing Home, Nandyal. And I would request the chairpersons to please introduce the speaker, Dr. A. Sridevi. Chairpersons, please.
No one joined Nivedita.
Okay, fine. Then Dr. H. Sridevi ma'am is an associate professor, Department of Obs and Gynae at GMC Ongole. She is an undergraduate from Kurnool Medical College and a postgraduate at SV Medical College, Tirupati. A gold medalist, got the Best Doctor Award twice from the District Collector, trained in Harvard for the Diploma in Diabetes Management, and a member of MU. So I think she's really the perfect choice to be delivering a talk on management of obesity in pregnancy. Over to you, Dr. Sridevi ma'am.
Ma'am, good evening, ma'am. Good evening, Shesi Sai sir, Radha Lakshmi ma'am, Venkatramana sir, Patel sir, Monica ma'am, and all the senior faculty for giving me this opportunity on this excellent webinar series, ma'am. Ma'am, can you please share my
topic, ma'am? Excuse me, 1 minute. Dr. Tamarveni, the chairperson, joined. Tamarveni. Yeah, Tamarveni joined. Hello. Tamarveni, are you able to hear me? Let carry on. Sridevi, you carry on.
Yes, ma'am. Ma'am, I have given PPT to Monica, ma'am. She told she'll share it in the.
Monica Gupta?
Yes, ma'am. Monica Ubbarda.
Umarband. Yeah,
Yes,
Monica. Monica ji. Monica, are you there? Monica? Hello?
Madam, shall I share it in the group, ma'am?
Yeah, I'm calling Monica. Sridevi's PPT you have to share. She has shared with you. Yeah, Sridevi, Monica is sharing.
Yes, ma'am. Yes.
Ma'am, until your CV opens, I'm sorry, until your slide deck opens, I think you can just start reading it out in the meantime till
Okay,
the
ma'am.
slide deck opens.
Okay, ma'am. Then I'll go through, ma'am. So my senior colleague, the Uma madam, is our my senior ma'am in the Karnool. She has given excellent presentation regarding the obesity, ma'am. So coming to my topic, obesity in the pregnancy. So the incidence of the obesity in the pregnancy in the antenatal population, we are having an incidence of 21.3%, ma'am, and around 47.3% of the pregnant women are having high BMI. So in this talk, we'll go through the pregnant women who are having the high BMI of more than 30 kg per meter square. And what are the major risk factors which are associated with high BMI are, so she may develop more chances of developing preeclampsia, gestational diabetes mellitus, increase the cesarean section rate, difficulty in assessing the fetal size, and also monitoring of the fetus will be a challenging task in the woman having high BMI. So coming to the pre-pregnancy care in the woman having the obesity, the preconceptional period and also contraceptive counseling. So that is the best time where we can counsel the woman to optimize her weight before planning her pregnancy. So all women of the childbearing age should optimize their weight. So we should measure their height and weight and calculate their BMI. And any woman having BMI more than 30, we should counsel them regarding the effects of this obesity on the pregnancy and outcome. So weight reduction overall, it reduces the maternal complications and fetal complications. So the risks compared to the high BMI in a pregnant woman are, there will be more chances of miscarriages. She may develop gestational diabetes mellitus, more chances of thromboembolism, and also there will be induced and prolonged labor, increases cesarean section rates, and also anesthesia complications, more chances of developing postpartum hemorrhage, more chances of getting wound infections, increased maternal morbidity and mortality is increased, and also postpartum she may face the initiation and also maintenance of the lactation problem also she'll be having.
Sridevi, the slides are not moving.
Yes, ma'am. Shall I go through, ma'am? Continue it.
Yeah, Monica.
Yeah, you can continue. Continue, ma'am.
Yes, ma'am. So coming to the risks to the infant, there is a more chances of developing congenital anomalies to the newborn. There is a chance of developing stillbirths and prematurity, macrosomia, and also neonatal deaths. And the nutritional supplementations which can be given are the 5 milligrams of folic acid should be supplemented preconceptionally 1 month prior to the pregnancy, and that should be continued till the first trimester. And these women, as they're more prone to develop preeclampsia, we can also start them on aspirin 150 milligrams from the 12 weeks of gestation, and it can be continued up to the birth. And as the Uma madam told, they may also have the vitamin D deficiency, so it can also be supplemented during the pregnancy. So this is the preconceptional care. And coming to the antenatal care, we should have all the facilities and equipment to manage the woman having the high BMI. So documentation should be given. What are all the facilities which we are having to treat this pregnant woman? So we should have large BP cuffs, weighing scale should be there, appropriate beds, trolleys, and transfer equipment should be there. And as these women are more prone to develop the thromboembolic episodes, so compression stockings and pneumatic devices should be present, and environmental risk assessment is mandatory. And monitoring during the pregnancy.
Please change to the next 4 slides. 4 slides more, please. So, madam, you will come to the topic which ma'am is speaking. Yeah,
yeah.
Yes, ma'am. Next slide, ma'am. So appropriate BP cuff, yes, ma'am. Monitoring during pregnancy. So initially at every first visit, initial at 10 weeks of gestation, BMI should be recorded. That is booking BMI we should take, and reweigh the woman again in the 3rd trimester. And normally with a woman having normal BMI, symphysis fundal height measurements on 24 weeks of gestation helps us to monitor the growth of the fetus. But here with high BMI, the serial symphysis fundal height measurements may not be helpful. So preferred method is to measure the fetal growth by ultrasound, ma'am. And these women, they are more prone to develop anesthetic complications. So BMI more than 40, definitely we should make an antenatal anesthetic stifler should be there. and they will be having a difficult IV axis. Second line should also be secured. Regional anesthesia difficulties will face increased airway and intubation difficulties, and also higher risk of desaturation, and they may develop atelectasis. As I told, with hypertension and preeclampsia, with high BMI more than 35 kg per meter square, that is one of the moderate risk factors for women developing preeclampsia. And the important step here is monitoring of the appropriate BP cuff should be there for hypertension recording, blood pressure recording. And class 2 obesity women, they are more risk of developing preeclampsia. And aspirin 150 milligram should be supplemented from 12 weeks of gestation if the woman is having more than 2 risk factors. So the risk factors are women having BMI more than 35, if she is a primigravida, age more than 40 years of age, and also if there is a family history of preeclampsia, and also multiple gestation. These are the risk factors which should be taken into consideration. So another important risk assessment, what we have to do in the woman having the high BMI is the venous thromboembolism risk assessment is there. According to the RCOG, antenatal risk assessment score is there, and also postpartum risk assessment score is there. Depending upon the score assessment, we have to go for the thromboprophylaxis, either with a therapeutic dose or the prophylactic dose of this heparin and other anticoagulants. So this is a very important task in a woman having high BMI. And coming to the labor and intrapartum care, there is increased induction chances and also increased emergency cesarean section rates. There is an increased risk of shoulder dystocia, and we have to keep the IV cannulas. As I told, anesthesia complications will be more. So early anesthetic involvement should be there when we are managing the woman with high BMI. Postnatal care and breastfeeding. As we told that in women having high BMI, initiation and also maintenance of the lactation will be difficult. So we should encourage the antenatal breastfeeding support and also monitor for the wound infection in the postpartum care. And also the risk of, as I told, postpartum risk assessment should be done again in women having high body mass index. That's so key take home message here is the maternal obesity significantly increases the obstetric risk. Pre-pregnancy counseling is crucial. Multidisciplinary management improves the outcomes, and early planning reduces the maternal and fetal morbidity. Madam, one more PPT is there, madam, regarding the intrapartum management, ma'am. Can you please share that, ma'am? Management. So as we discussed, obesity in obstetric care, it involves the multidisciplinary approach. So here, everything, the pregnant women, they should be educated and counseled regarding what are all the risks she may face with this high BMI. She may develop preeclampsia, she may develop gestational diabetes mellitus, newborn and also neonatal complications will be more. All these should be told. Booking BMI should be recorded, and also electronic recordings we are having, we should note in that, and also handwritten records also we should document if she is having a high BMI. So BMI classification, my senior madam told class 1, class 2 and class 3. And as I told, the antenatal population is having around 21.3%. Madam, next slide, ma'am. So these are all the maternal risk factors: venous thromboembolism, metabolic syndrome. These women should be screened for gestational diabetes mellitus. They may land up in preeclampsia. Mechanical, that is during labor and delivery, induction of labor, prolonged labor, shoulder dystocia, emergency cesarean section, PPH and wound infection. They are usually associated with a higher maternal morbidity and mortality. Yes, ma'am. So definitely, if the woman is having high BMI, there is intrauterine exposure, the fetal development within the obese maternal environment. It has a structural impact of developing neural tube defects, spina bifida, cardiovascular anomalies, prematurity, macrosomia, neonatal death, and long-term legacy also metabolic programming. This child is also in the future she may develop diabetes, gestational diabetes and obesity also, ma'am. So the goal is to reach the healthy BMI before conception. So measure BMI at all childbearing women, mandatory counseling regarding the lifestyle, nutrition and contraception. This has a great impact, as my senior madam told, that is reduction of 5 to 10%, minimal blood loss, some amount of weight loss also. It reduces the stillbirths, preeclampsia, reduces the incidence of fetal macrosomia, and also increases the vaginal birth after the cesarean section. So any woman, if she has undergone a bariatric surgery, a mandatory period of 12 to 18 months contraception should be advised after the bariatric surgery. And also she requires a consultant-led care. And these patients with obesity, even though after treatment, they may suffer from acute malnutrition. So frequent screening of them for the deficiency of iron and B12 and folic acid should be done. And mandatory referral for the dietitian should be done if she has undergone a bariatric surgery. And there is definitely these weight reducing drugs, orlistat, lorcaserin and phentermine. These are having the effect on the newborn oval cleft palate. So these anti-obesity drugs are contraindicated during pregnancy and also in the lactation, as these drugs are excreted in the breast milk also. So there is no role of these anti-obesity drugs during pregnancy. So prophylaxis is mainly we have to supplement 5 milligrams of folic acid 1 month preconceptionally and throughout the first trimester. Aspirin 150 milligrams should be given starting from 12 weeks if the BMI is more than 35 kg per meter square, and vitamin D supplementation should be given for obese women with class 1 to class 3 obesity. So surveillance here because of the maternal obesity, the abdominal palpation will be having a difficulty in assessment of the fetal size. Fetal heart rate auscultation will be difficult. Intrapartum assessing of the fetal distress or fetal monitoring will also having the difficulty. So here the symphysis fundal height measurement may not help in women with obesity. We have to go with ultrasound monitoring. And aneuploidy screening, transabdominal mucotranslucency visualization is often obscured or technically difficult to go for transvaginal ultrasound or other non-invasive tests like NIPTs for accurate measurements or accurate things. Anesthetic complications. As we told, the woman having a high BMI, obstetric anesthetic early referral should be there. There will be difficulty in the airway management, high probability of difficulty bag and mask ventilation and failed intubation. And also there will be prolonged decision to delivery time due to difficulty in establishing the regional anesthesia. We will be having a chances of epidural failure. So we require specialized equipment and also experienced senior obstetrician, senior anesthetist should be involved in when we are dealing the case of a woman having high BMI, and 1/4 of the maternal deaths due to cardiac arrest are related to the anesthesia complications. So we should have a door with should be trolleys which can pass environmental risk assessment. Infrastructure also we should assess. We should have a required cuff sizes of 12 into 23 centimeters, 15 into 33 centimeters, and thigh cuff size should be around 18 to 36 centimeters. And these cuff sizes should also be documented in our records. We should have a armless chairs if available. And also overmat and also transfer trolleys, everything should be kept ready. These pregnant women, they are also more prone to develop with high BMI pressure source. So because of this high obesity, so we should also counsel them regarding the pressure. So that is initiate documented skincare plan in the 3rd trimester, intrapartum repositioning, hourly rotation to prevent the pressure source, moisture management, particular attention to subpanicular skin folds, wound vigilance, daily inspection of the C-section sites and the perineum. So immobility carries a silent risks. Active management is required to prevent the tissue necrosis. Postnatal care, as we thought that breastfeeding initiation and maintenance will be delayed here during in the obesity. Impaired prolactin response to suckling will be there. So standard care is insufficient. Antenatal education. So action what we have to take is antenatal education. Manage expectations regarding the delay. Early support should be given throughout the postnatal period, and also positioning, also assistance, and also techniques which can help us for a better feeding of the newborn. We should educate and counsel the mother. So the summary of the obesity in pregnancy. At the take-home message is initial booking BMI should be taken around 10 weeks of gestation. Again, reweigh the women in the third trimester. It is a team effort involving the multidisciplinary involvement of obstetrician, anesthetists, midwives, and we have a consultant-led care in high-risk pregnancies. Environment, here pre-labor checks, appropriate cuff sizes should be there, bed capacity, transfer devices, and also door widths we have to check. And clear non-judgmental counseling and communication should be told to the pregnant woman and also to her partner. Thank you, ma'am.
Yeah, Chairperson, Dr. Tamaraveni, your words regarding this talk on obesity in pregnancy management by Dr. Sridevi. Yeah, you have to unmute Tamaraveni. Tamaraveni, unmute. Unmute.
Unmute. Okay. Hello. Can you hear me?
Yeah.
Yes, ma'am.
Audible. Yes,
Yes.
ma'am.
Thank you so much, Dr. Sridevi. You are given the good lecture about obesity in pregnancy. This is a new chapter what actually heard now. Because of, I want to know how many doctors and any thesis has done in your institution about this obesity in pregnancy?
Madam, now our postgraduate, she is doing, madam, obesity
Is
with
the best one, yeah.
Yes, ma'am.
It is a-
She is
yeah.
doing, ma'am.
Yes.
After joining this webinar only, I have heard this obesity topic, ma'am.
Yes,
And
yes,
I
I
have
want
learned
to
so
know.
many
Yes.
risks of maternal and newborn.
Yes,
This
yes,
so
yeah. Yeah,
so
yeah.
we counsel the mother, ma'am, regarding the this associated with this, ma'am.
Is actually the maternal and the fetal morbidity mortality has increased in obesity in pregnancy. This
Yes,
is very, very good chapter, the new chapter what actually now I heard. Thank you so much, Sridevi. You
Yes,
given-
thank you, ma'am.
Thank you so much. What is your conclusion? I want to know because of you told the obstetrician, anesthetist, nutrition should take place. During the delivery, what I feel in theater, when you are doing the section or you are doing in the labor, that pediatrician should be
Yes, ma'am.
present there. That's very important because the
ma'am.
baby, we don't know how the fetus comes out and
ma'am.
what is the position of that. You said
Difficulty will be there in the delivery
yeah,
of the
definitely. So the intubation also very difficult for the anesthetist. Delivery of the baby also in
Booking BMI should be calculated, ma'am. We should educate
That's
our
right.
postgraduates and interns to record
Yeah,
the
yeah.
BMI, ma'am. Yes, ma'am. Now we
Yeah.
are doing, ma'am.
Yeah, every patient who is having, you have the doubt about the height and weight, you should go for the thorough investigation about your BMA, whatever every patient should get that BMA done. That is
Yes,
my,
ma'am.
this thing.
Thank you.
Thank you so much. Thank you so
Thank
much, Devi, once again.
Thank you, ma'am.
Thank you.
Thank you, Sridevi ma'am, for the excellent deliberation. And it's really very troublesome. This is a new, I think it's a new problem for obstetricians. Not that we are bogged down with others, but another problem, major problem, which we are facing now is obesity in pregnancy. And thank you for covering all the topics. Thank you, ma'am, for taking up the thesis for your students. And I now request my co-coordinator to take over the session third.
Thank you.
Monica, ma'am. Thank you, ma'am, for sharing the slides, ma'am. Thank you, ma'am.
Dr. Monica?
Hello.
Yes, Shatabdi.
Am I
think you
audible?
can.
Yes.
Yes, Shatabdi.
Yes. There was some network issue. After those two lovely lectures by Dr. Uma Devi ma'am and Sridevi ma'am, we move on to our third session for the day. We have a talk on again one of the very important pertinent topics of today, that is the strategies for successful outcome in GDM. The speaker is Dr. Sujeshri Sangeeta ma'am. And we have three chairpersons with us. Our first chairperson is Dr. Usha Rani ma'am. Dr. Usha Rani ma'am is the president of the Kadapa OBGY Society and one of the senior gynecologists in Kadapa. Welcome, ma'am. Our next chairperson is Dr. Manikya Rao sir. Sir is the ex-general secretary of KOGS and the ex-president of the AP Gynae Society. And he has been the organizing secretary for the 5th APCOG. We welcome sir. And our next chairperson is Dr. Sharda Bandaru ma'am. Ma'am is a professor in the Apollo Institute of Medical Sciences and Research and vice president of the Chittoor Obs-Gynae Society. I would request, I think Dr. Usha Rani ma'am is there. I would request Dr. Usha Rani ma'am to kindly introduce Dr. Sujeshri Sangeeta ma'am and carry on with the talk.
Thank you, doctor. So, thank you, Dr. M.C. Patel, sir, and Dr. Radha Lakshmi for making a part of this platform. So now I'd like to introduce Dr. Sujeshri Sangeeta. She's an experienced obstetrician and gynecologist and laparoscopic surgeon, and she's the founder secretary of Bhimavaram Obstetrics and Gynecological Society. And then she was to lead the first IVF center in Ongole. She's educated from MS Ramaya Medical College, Bangalore, and did her OBG and Gynec in JJM Medical College, Davangere. Doctor, I'm also a student of Davangere Medical College. Nice to meet you.
Nice to meet you, ma'am.
Okay.
And it's nice to meet alumni from our institute. Thank you so much, ma'am. And ma'am, thank you for the kind introduction. Let's move on, ma'am.
Yes. Please kindly take over and start your. We are very eager to hear your strategies for successful outcome in GDM. Okay.
Thank you so much, ma'am.
Okay.
Thank you.
Thank you.
So firstly, very good evening. It's really late. So very good evening to all the delegates in today's program and all my colleagues who've logged in. Firstly, I would like to thank Dr. M.C. Patel sir and Dr. Radha Lakshmi ma'am for this wonderful opportunity. And I hope I do justice to this topic. So the topic for today is strategies for successful outcome of GDM. Hyperglycemia is one of the most common medical conditions women encounter during pregnancy, and almost 1 in 6 live births occur to women with some form of hyperglycemia, and 84% of which are due to GDM. As you can see here, diabetes in pregnancy is divided into pre-existing diabetes, which is where the individual has been diagnosed prior to...
Yes, slides not moving. Nilesh, slides not moving. Monica, Shatabdi.
Madam, actually,
The slides not moving.
I think there must be a technical error because I'm sharing it right now, ma'am.
Okay.
Madam, you have to click on enable editing, then
it says
you will
sharing.
post.
Let's see, I'm sharing it right now.
Ma'am, it's okay. Even if it is not in the slide share, if you keep moving the slides, maybe they'll move.
I have. Can you see them now, ma'am?
Yeah, now they're moving. They're moving.
Now they're moving. Should I proceed?
Yeah. Yeah, continue.
Yeah, now it's okay, ma'am?
Yeah.
Okay. So as I said, diabetes in pregnancy is classified into pre-existing diabetes where the individual has been identified prior to conception.
1 minute. Make it full screen.
Ma'am,
when she's making it full screen, it's not moving. The slides are not moving when she's making it full screen.
Okay. Should I try it again? Just see, ma'am. Is it moving?
Yeah, when you keep it in this mode, they are moving. But when you keep it on full screen, then they are not moving.
Okay. So should I go ahead now, ma'am?
Yeah, please go ahead.
Okay. So as I said, so it's diagnosed prior to pregnancy, or it is diagnosed during the first time during pregnancy, where during routine blood investigation, you do a fasting blood glucose, which is more than or equal to 126. and any random blood sugar is more than 200, there we diagnose them to be diabetes, which would have been missed prior to conception. And gestational diabetes mellitus, it is likely to occur later in pregnancy because it occurs due to insulin resistance and imbalance in hormonal milieu. Here, following a 75 gram GTT, the 2 hours post-glucose value is more than 140 milligram per deciliter when you diagnose them to be GDM. Pregnancy by itself is a diabetogenic state. So pregnancy induces insulin resistance because of secretion of human placental lactogen, cortisol, and also there is increased destruction of insulin because of kidney and placental insulinase enzyme. And there is also a shift towards lipolysis because the mother utilizes fatty acids as a precursor versus glucose because she's sparing it for the fetal demand. So as you can see in this diagram, here there is an interplay where there is insulin resistance due to the placental lactogen. There is a shift towards hepatic glucose neoproduction. There's an increase by almost 15 to 30% to meet fetal
So
demand.
your slides aren't moving anymore.
Okay. I'll go back to the previous thing.
Yes,
Now
yes,
it's
yes.
fine. Yeah, let's stick to this, ma'am. So then also there is lipolysis happening. So when these changes occur, if the maternal beta cell is unable to compensate for the same by increasing the number and function, then it will exhibit as gestational diabetes mellitus. So when there is failure of compensation of the maternal beta cells, only then will it present as gestational diabetes mellitus. So coming to the screening aspect, you have a lot of bodies which have come up with their own screening modalities. Briefly, I'll just compare. Here, as you can see, you have NICE, IADPSG, which is nothing but the International Association of Diabetes Pregnancy Study Group, ACOG and WHO. In all of them, they're advocating universal screening except NICE, which says that they advocate selective screening where they identify high-risk population and only then offer them 75 grams GTT. I am explaining the same in the next slide, whereas you can see again, universal screening in all studies except NICE. Here they identify women with high risk factors like obese women, above a BMI above 30, previous macrosomic baby, previous pregnancy with GDM, first degree relative with diabetes, and ethnicity, where South Asians, Indian population come under that category. So these people are offered 75 grams GTT at 24 to 28 weeks. Only if she's had a previous history of GDM will they offer this at 16 to 18 weeks. When you compare it to all the other studies, all of them are offering GTT at 24 to 28 weeks, which is the standard. And there they then do the fasting 1, 2, and 3 post-star blood glucose. If the values are, any one value is elevated, then you consider them to be a GDM. ACOG recommends a 2-step procedure. Here also it is universal screening where at 24 to 28 weeks, they perform a 50 grams glucose challenge test irrespective of the fasting state. This is called as O'Sullivan test. Here, if the post blood glucose value for 2 hours is more than 140 milligram per deciliter, then they're asked to move on to the confirmation test, which is 100 grams GTT. Here, fasting state has to be maintained minimum 12 hours and they're offered 100 grams glucose, following which again fasting 1, 2 and 3 hours blood sample is assessed. And if according to Kaplan-Couston criteria, if it is more than 95, 180, 155 and 140 milligram per deciliter respectively, any 2 elevated values only, then they diagnose it to be GDM. But coming to India, the government of India, it supports the DIPSI criteria. Here, what is done is, irrespective of the fasting state, you offer 75 grams GTT to the individual and 2 hours blood glucose level above or equal to 140 milligram per deciliter is taken to be GDM. And if it is between 120 to 140, you take it as gestational glucose intolerance. Now, to explain the third line, I will move on to the next slide. Here, Dr. Veeraswamy Sheshia, who's known as the father of gestational diabetes in India, he is now recently in 2023, he's come up with the concern where prediction of GDM becomes more important to improve the neonatal outcome. Because if the woman is maintaining a persistent state of euglycemia, then the baby is not exposed to hypoglycemia, thereby preventing complications. So what he's advocating is, preferably at 8 weeks, that is at the end of 2 months, if you offer glucose tolerance test to the individual and her postprandial 2-hour postprandial blood glucose is more than 110, then you identify them as individuals at risk of developing GDM and offer them MNT, which is nutritional therapy and physical activity. Following lifestyle modification, if after 2 weeks you see an improvement in their blood glucose levels, you continue the same. Otherwise, you start them on metformin. Now, why have they come up with this? Because the fetal beta cells, they start secretion of insulin from 11 weeks of gestation. If you identify hyperglycemia, maternal hyperglycemia prior to them, you're preventing the baby from being exposed to maternal hyperglycemia, thereby leading to altered insulin production, which will in turn affect the neonatal outcome. So what is this test according to DIPSI criteria? Irrespective of the fasting state, you give them 75 grams of anhydrous glucose, which is mixed with 300 ml of water. They have to consume it within 10 minutes. If the patient vomits within half an hour, you would ask them to repeat it on a subsequent day. Otherwise, you can continue. Here, you take a blood sample 2 hours following ingestion of glucose. They should not consume anything in between. And here, what we have to realize is the 75 grams of anhydrous glucose, what we're giving is the commercial form. So either it's a glucon D or any glucon formation. What is said is 82.5 grams of that is equivalent to 75 grams of anhydrous glucose. A lot of times we ask our lab people to give 75 grams, which they just measure and give. But now you have to make note, it is to be measured as 82.5 grams of commercial formulation. So here, as you can see the recommendation, pregnant woman comes. So what time do you have to do this test? As soon as she enters your antenatal clinic, irrespective of the trimester, even if it is the early part of pregnancy, you have to offer them GTT, 75 grams GTT. If at that point of time, it is more than or equal to 140 milligram per deciliter, you diagnose them to have GDM and treat them accordingly. If you see that it is less than 140, then you have to repeat it again at 24 to 28 weeks. Even then, if it persists to be negative, based on high-risk stratification, you can offer the same at 32 to 34 weeks of gestation. What are the advantages of DIPSI? In our setup, you will lose patient to follow up if you ask them to come back at a certain time. Because here, women in the lower strata, they travel from very long distances. So once they approach you, that is the best time to perform this, irrespective of the gestational age. And after you perform the test, there are also studies which say if you don't even have an access to a chemical analyzer which gives immediate results, there is no harm in just doing a glucometer sample and giving them immediate results, because sometimes if you ask them to come back the subsequent day also, you may lose them to follow up. So in our population, doing it irrespective of fasting state, one-step approach where you ingest glucose and take it 2 hours later with immediate results is the best way to identify these individuals who are having GDM. So diagnostic accuracy of diabetes prediction using a DIPSI versus other methods like Carpenter-Houston method, and also National Diabetes Data Group was done. And it was found that the accuracy was almost 95.8 to 95.52% when you compare both the studies, which is a pretty good accuracy. So coming to management of GDM, now let's categorize into pre-pregnancy. See, treatment of GDM actually begins even before she gets pregnant. Because when they come for pre-pregnancy counseling, it is always better to perform routine investigations, especially see if their random sugars are elevated and check their HbA1c. Periconceptual control of hyperglycemia is very important, because if it is not maintained, there's a very high likelihood of them developing congenital anomalies. Even if the patient is obese, this is the right time for us to address that, advise them to lose weight and modify their diet. In case you identify them to be diabetic on this visit, it is better you initially start them either on oral hypoglycemic agents or insulin, and then ask them to conceive, preferably after your HbA1c is less than 6.1%, to avoid congenital anomalies and for better obstetric outcome. Early initiation of therapy is very important for good outcome. Here our target is to maintain the fasting sugars below 95, 1 hour post meal at less than 140 and 2 hours post meal at less than 120. In spite of maintaining such stringent cutoffs, a lot of time we see that the fetus could be either macrosomic or small for gestational age. To avoid such complications, newer studies have come forward where they're using ultrasound parameters to modify treatment strategies. Here, if the abdominal circumference is more than the 75th centile, we keep the fasting glucose cutoff at less than 80 and postprandial 2 hours at less than 100. If AC is less than 75th percentile, then we relax the cutoff where the fasting is taken to be 100 and 2 hours postprandial less than 140. By doing this, we are helping in a little better nutrition for the fetus and improving the weight gain when the centile is less, thereby reducing the outcome of either having a macroscomic baby or small for gestational age baby. Here, why we are seeing this scenario is when you're offering dietary restriction, usually what we do is we either have excessive calorie restriction, which will compromise the baby's growth, or if you're not doing adequate restriction, you will have a large baby. So maintaining an dietary restriction is like walking on a tightrope. It is very difficult to get the correct dietary plan, which suits an individual. Here, when it comes to management, we have to endorse the importance of self-monitoring of blood glucose to the individual patient. Why do we need this? This is required for us to intensify treatment where there is very poor control. So here we have to perform fasting 2 hours post-breakfast, post-lunch and post-dinner, initially on alternate days till we standardize the dose of either their oral hypoglycemic or insulin. Now, fasting glucose, does it play a role in whether we have to initiate insulin therapy? No. Fasting glucose has more importance in predicting the perinatal outcome. Now you've performed a fasting glucose, you're titrating the dose of insulin for an individual. Here you see there is fasting hyperglycemia. Do you immediately increase the insulin dose? No. There is an entity called as SOMOG. Here what happens is at around 3 a.m. in the night, there is occasionally a drop in hypoglycemia when the insulin dose is excessive. This causes a rebound gain of sugars in the morning, but this is a rebound to hypoglycemia. So here this is occurring because the insulin dose is in excess, not less. So what you have to do is you always have to check the 3 a.m. sample when you have hyperglycemia to decide, because is it a rebound phenomena or is it happening because there is a inadequacy of the insulin dose. Medical nutrition therapy, which is the first line therapy when you're treating a woman with GDM. Here, medical nutrition therapy is nothing but carbohydrate control, maintaining a balanced meal plan. So here, what we have to aim is adequate nutrition for both the mother and the fetus. So there is adequate weight gain of the fetus. Here, you have to prevent excessive calorie restriction, which will lead to hyperketonemia and ketonuria of the mother, leading to ketosis. You have to ensure there is no postprandial hyperglycemia and also hypoglycemic episodes. So it is such a difficult walk to achieve that meal plan. So it is always better to consult a dietitian or a health provider who are qualified in this. So just to explain the GDM diet plan, here you divide it into 3 major meals and 3 minor meals. And as you know, the calorie value is the same in the first trimester. You only increase the number of calories in the second and third trimester to around 350 calories per day. But when it comes to GDM diet, we're not doing it trimester wise, we're doing it based on the BMI. So if the BMI is less than 25, you advise in 3000 calories per day. If it is 25 to 30, around 2500, and more than 40, you decrease it to 1250 calories per day. And how are these calories further divided? 45% is carbohydrates, 30% protein, preferably lean protein, and 25% fat, which is unsaturated fats. These are the fats which will decrease the LDL and increase the HDL. Where do you derive unsaturated fats from when it comes to oil? Primarily sunflower, safflower, canola, and olive oil, and nuts, pumpkin, flax seeds, walnuts, peanuts, cashew, and also avocado. Fish is a very good source of polyunsaturated fats, which are rich in omega fatty acids, especially salmon, mackerel, and sardines. So diet rich in fiber and low glycemic index are very helpful in avoiding insulin therapy. So diet plays a very important role in the outcome of GDM patient. Physical activity is also equally important. Unless contraindicated, a woman with GDM has to perform physical activity. What is the optimal timing of or post meal? Around 30 to 60 meals following a meal. 60 minutes, following a meal. This is highly effective in controlling your postprandial glucose. Intensity of moderate intensity. And recommended activities are either walking, light weights, if done, if they're already acclimatized with it, and if they have someone to supervise, and also prenatal yoga is beneficial. Resistance and flexibility exercises require supervision. Walking can be done by themselves. Benefits: this will reduce the need for insulin, lower the risk of cesarean delivery, and also help manage gestational weight gain, and also in some instances reduce the dosage of insulin also. So there's these studies also which prove that exercise during pregnancy will help in improving the outcome of gestational diabetes. So what is the target weight gain here in individuals with GDM based on the BMI? Women with less than 8.5 who are underweight, the weight gain is a little more. We expect it to be around 12.5 to 18. If it is BMI of 18.5 to 24.9, which is normal BMI, a weight gain of 11.5 to 16 is advised. If it is 25 to 29.9, they're considered overweight, 7 to 11.5 kgs, and more than 30, where they're obese, is 5 to 9 kgs. So the calorie intake and the total weight gain, they're dependent on the BMI of the individual when it comes to GDM management. So just to summarize it, you have a pregnant woman with GDM. Initially, you offer medical nutrition therapy and exercise. Then after 2 weeks, you again check her 2 hours postprandial blood sugars. If it is less than 120, you can continue the same, but monitor at frequent intervals. If it persists to be elevated more than 120, then you have to either start them on insulin therapy, which is the gold standard, or oral hypoglycemic agents like metformin. Monitoring should be continued initially till the therapy is stabilized. Fasting and 2-hour PPBS every third day or every alternate day once it's established. If it is insulin therapy, more frequently, and if it's metformin, bi-weekly sufficient. Now coming to the medical management, your MNT and physical activity has failed. Now you have to start them on medicine. So insulin is the gold standard to treat both patients with GDM and pregestational diabetes, and it offers good glycemic control and also doesn't cross over to the placenta and lesser incidence of hypoglycemic episodes. Insulin management must be individualized. On an average, a pregnant woman would require approximately 0.7 units per kg daily, initially in the first trimester, which increases in the second and third. So what the type of insulins which are available? You have short acting, which take 30 minutes to act, and they work for 1 to 2 hours. Intermediate acting, onset of action is 1 to 2 hours, and they have sustained action for around 14 hours. This intermediate acting insulin is usually given as 2 doses per day. Rapid acting, immediate onset. Long acting insulins, studies are still not there to talk about the safety profile in pregnancy. And long acting insulin glargine, it is not actually recommended because studies have shown that the incidence of macrosomic babies are more with the usage of that because of its mitogenic property. So now how do you set the dose? Now you calculate the total insulin required. You divide it into 2/3, which is given in the morning, and 1/3 at night. The morning dose is further divided as 2/3 of NPH, which is nothing but intermediate acting insulin, and 1/3 of short acting. Pre-dinner, it's again half of intermediate and half of short acting insulin. Our aim is to have the fasting blood sugar below 95, post 1 hour glucose below 140, and post 2 hours below 120. Compliance is a huge issue with insulin dosing, where you have to sensitize the patient to the importance of maintaining euglycemia for a better neonatal outcome. Now you're doing the blood glucose monitoring. She's on insulin. You see that the fasting blood sugar is normal, but the 2-hour PPBS is elevated. Here, what you have to do is, for that meal, you have to add 2 hours, 2 units of insulin. And advise them to increase the NMNT and the physical exercise. If both the levels are elevated, then you add 2 hours, 2 units to the pre-breakfast dose, and also increase 4 units to the pre-dinner dose, because that has to accommodate the fasting value. If only PPBS is elevated, be it your post-breakfast, post-lunch, post-dinner, whatever, for that insulin dose, 2 units can be increased. If fasting is elevated, then you have to increase 2 units only in the pre-dinner insulin. This is how you titrate the insulin dose based on your sugars, that is fasting and 2 hours postprandial. Now coming to the oral hypoglycemic agents, metformin is used. It's a class B FDA. It's a biguanide which inhibits neogluconeogenesis, thereby increasing peripheral uptake of glucose and maintaining a euglycemic state. So metformin can be given to individuals with poor compliance with regard to insulin dosing or individuals who refuse insulin. So here initially metformin is started and you titrate the dose. Initially you start it at 500 milligrams OD or BD based on the sugar values, and you can increase it up to 2,500 to 2,000 milligrams per day in divided doses. If there is no improvement with metformin along with MNT and physical activity, then you would add insulin. So there are two trials which show that metformin is safe. You have the MIG trial, which is metformin in gestational diabetes mellitus. Here, use of metformin is found to reduce the dose of insulin and total weight gain of the individual. TOFU trial is for the safety profile. Here, babies of mothers who were in the MIG trial were studied retrospectively, and it was seen that they had no long-term outcomes. So this is a study to assess the efficacy. It was found that oral anti-diabetic drugs, especially metformin, was very beneficial in controlling the sugars and also reducing the dose of insulin. Just to compare both, as everyone knows, metformin is oral. There's a standard dose. It can be stored at room temperature, better compliance, minimal side effects. With insulin, it's an injectable form. You have to keep monitoring the dose and titrating it as and when required. Poor compliance, and it does cause hypoglycemic episodes during the initial titration. How do you monitor the blood glucose with your medical management? It has to be done at least 4 times. As mentioned, fasting, post-breakfast, post-lunch, post-dinner. And after achieving the target level, self-blood glucose monitoring has to be done with a glucomonitor, but lab monitoring can be reduced to once a month up to 28 weeks, and between 28 to 32 weeks twice a month, which is every 2 weeks, and beyond 32 weeks, every week lab monitoring has to be done. The other parameters which have to be monitored in pre-gestational diabetes, because they have been exposed for a prolonged period, is a retinal examination and also check for microalbuminuria. Coming to fetal surveillance. So in the first trimester, initial dating scan to check for the viability, then NT scan is done at 11 to 14 weeks. If NT is elevated, there is an increased risk of cardiac anomalies. Second trimester, TIFA is done at 18 to 20 weeks. Fetal echo is advised at around 22 to 24 weeks in individuals who have had pre-existing diabetes, because there is periconceptional hyperglycemia, which increases the risk of cardiac anomalies, and also in individuals who are obese, where a proper evaluation of the heart has not been done at the time of TIFA. Third trimester, you have to do monitoring every 4 weeks to check for the growth, fetal growth. Daily fetal kick count has to be maintained, which is very crucial. And if the pregnancy goes beyond 38 weeks, intensive monitoring is required. See, usually in the last 2 weeks of pregnancy, there is a higher incidence of stillbirth. And the biggest risk factor for that is a large for gestational age baby. What happens is when you're monitoring the CTG and the Doppler, they identify the placental function. Here, because of maternal hyperglycemia, there's a state of fetal hypoxia and acidosis. That is a metabolic imbalance. And your routine CTG and Doppler will not be able to identify that. So you have to be very careful, sensitize the patient to the risk of stillbirth, and individualize every patient and decide whether you want to continue the pregnancy beyond 38 weeks. So timing of delivery after 38 completed weeks, if it is a complicated GDM with poor glycemic control, it is better to terminate the pregnancy. If it is favorable for vaginal delivery, you can induce them, or if the weight is more than 4 kgs, you can offer them elective cesarean section. So here, GDM is not an indication for cesarean section. It is either fetal distress or when you have poor glycemic control, large for gestational age babies, then you can consider cesarean. If at 38 weeks there is good glycemic control, it is an uncomplicated GDM, the baby is not large, it's not macrosomic, then you can weigh your pros and cons and decide if you want to continue the same. So coming to the labor management, here, whether it is hyperglycemia with or without medical management, admission CTG partograph has to be maintained. You have to monitor her sugars every 2 hourly, and also start them on IV fluids, initial first stage management. When it comes to second stage controlled ARM, you have to anticipate shoulder dystocia, assisted vaginal delivery, considering the weight of the baby. Neonatologists must be available because there's always a risk of neonatal hypoglycemia. Third stage, active management. You should be prepared for traumatic atonic postpartum hemorrhage. So management during labor, maintaining a glycemic control between 70 to 120. Glucometer monitoring has to be done. Urinary ketone bodies have to be also evaluated, because especially in individuals with pre-gestational diabetes, they're more likely to develop ketosis. And if they're on insulin, the previous night dose of intermediate acting insulin should be given, but the morning dose has to be avoided. Usually labor is an active process, so there is calorie burning, so glucose is utilized. If the sugars are less than 125, you can start them on dextrose. Post-surgery, early ambulation, pneumatic compression, and increased fluid intake to prevent thromboembolism. So just a small table to explain the insulin titration during labor based on the glucose values. So immediate postpartum care. If it's a pre-gestational diabetic woman, you have to resume her oral hypoglycemic agent. And if it's insulin, you can reduce the insulin dose by titrating her blood glucose levels. But if it's a patient with GDM, you can stop her medical therapy and insulin also, because in a lot of instances, the sugars get normalized following delivery. Postpartum screening, you check for their sugars 3 days after delivery and then offer them GTT at 6 weeks of gestation, because you want to identify women who will persist to be diabetic or women with impaired glucose tolerance. So once you do a 75 gram GTT, if the 2 hours post glucose value is less than 140, it is considered normal, euglycemic. If it is between 140 to 199, you take it as impaired glucose tolerance, and more than 200 is over diabetes. So risk factors for persistent GDM is when persistent fasting blood glucose levels are more than 126, there is diagnosis of GDM occurring in the first trimester itself, and a prior history of GDM without normalization of the glucose values. So contraceptives, you have barrier contraceptives which are safe. Long-acting reversible contraceptives like IUCD, Mirena can be advised. Progestogen-only pills are also safe. They can be started in the immediate postpartum period, even in women with cardiovascular and microvascular complications. Combined oral contraceptive pills are started 6 weeks if non-breastfeeding. And the contraindications for oral contraceptive pills are dyslipidemias, hypertriglyceridemia, high blood pressure, smokers, nephropathy, and women who've had diabetes for over 20 years. These are the references, and thank you all for your patient hearing. I hope I have done justice to this topic. If there are any queries, please, I'm willing to address them.
Usha madam, are you there?
Yes, yes.
Yeah, your words of wisdom.
Okay, thank you, Sangeeta. Thank you very much for your elaborated speech on this strategies for successful outcome in GDM. So we are enlightened with the speech. So no other queries or questions. You are very clear about that. Thank you, Sangeeta.
Thank you so much, ma'am. Thank you.
So I am having one question. So when you want to do blood sugar estimation in the first antenatal visit or before in the preconceptional period, to be that the blood sugar, postprandial blood sugar should be kept to be 120 and to start metformin. Please clarify regarding that.
Ma'am, if it is preconceptional, then the cutoff is fasting blood sugar is of 126. And if it is postprandial, if it is 1 hour, we take it as 140, and 2 hours is 120. And also simultaneously, you will also have to do a HbA1c for an average mean glucose for 4 weeks. But when it comes to your pregnancy, there is a slight variation in the cutoff. When it comes to in pregnancy, the cutoff is 95 for fasting. And for 1 hour post-glucose, it remains 140, and 2 hours is 120.
No. Regarding that metformin, starting of metformin in the first 8 weeks of pregnancy, control of embryogenesis.
Okay, ma'am, this is with regard to Veeraswamy Sheshaya's thing. So when you check for the glucose levels, initially when you're starting, where you take the cutoff as 110, your starting dose is 250 milligram, ma'am. It's not 500, as which is in later pregnancy. Here you start with 250 milligram BD, and based on that, you titrate the dose. And this metformin is safe initially, so there is no effect on embryogenesis.
Thank you. So next is the most important session by none other than our MC Patel sir. Sir is going to contest for FOXI presidential election this year, 2026. I request all the presidents and secretaries and all the participants to promote MC Patel sir from your societies and to cast your valuable vote and support MC Patel sir to win the elections in 2026 and to be our president of FOXI in the 2028.
Thank you, Radha.
So let me introduce the panelists of today's session. So our main moderator is none other than our MC Patel sir. And the main panelists are Sir Hanuman sir, are you there? Hanuman sir? So the first panelist is Dr. A. Sudharani. She is the Associate Professor of Obstetrics and Gynecology from Kurnool Medical College, Kurnool. She had more than 10 publications in various national journals. Her areas of interest are high-risk pregnancy and infertility. Next, Dr. Gayatri Vaishnavi. Gayatri Vaishnavi, CV, please. So she is the director of Anvita Advanced Fetal Medicine Center. She did fellowship in fetal medicine and worked as consultant in fetal medicine in Apollo Diagnostics, Kurnool. So she is the student of Kurnool Medical College, Kurnool. Thank you.
Good evening, ma'am.
Gayatri, for joining as panel member.
Thank you,
The
ma'am.
third panel member is Dr. Suchitra. Suchitra, CV, please. Suchitra is the professor of OBG from Department of Obstetrics and Gynecology, Government Medical College and Kurnool. She did her MBBS from KMC Kurnool, MD for Jipmar Pondicherry. Welcome, Dr. Suchitra. Are you there? Suchitra, not there. So Nagajyoti, she did her MBBS and MD from Kurnool Medical College, Kurnool. She is multi-gold medalist and senior consultant at RDT Hospital, Batalpalli, and she is now presently the treasurer of Anantapur Obstetrics Gynecology. Welcome, Dr. Nagajyoti.
Hi, madam. Hi, all.
And Dr. Baby Shalini, she is the secretary of Chittoor OBG Society, presently working as assistant professor in Chittoor Medical College. Madam is not able to, Shalini is not able to join because she is in duty. She has to attend one emergency case. Next CV, please. And Dr. Anita, she is the professor of obstetrics and gynecology from Vishwabharati Medical College, Kurnool. And her areas of interest are infertility, high-risk pregnancy, teaching experience of 18 years. And she is the member of Medical Education Unit, Vishwabharati Medical College, conducted various screening programs. Thank you, Anita, for joining the panel. Anita, are you there?
I'm there. Good evening, ma'am. Thank you, ma'am.
Yeah. Dr. R. Uma Devi, she is the assistant professor, Department of OBG, Tirupati. Presently, she is working as secretary, Tirupati OBG Society. Uma Devi, welcome. Uma Devi? Uma Devi is not there. Next CV, please. No, Tamaravani is not there. Next is Dr. Divya Teja. Dr. Divya Teja.
I am here.
No. You are the chairperson. They are the panelists. So Divya Teja is the assistant professor in Government Medical College, Nanjal. And she did her MBBS from Pinnamaneni Siddhartha Institute and MS OBG from Ashram. and presently consultant at assistant professor in Government Medical College, Nandyal. Welcome, Dr. Divya Teja. Divya Teja, are you there? Next, Ramakrishna Hanuman, sir. We know, all of us very well know about Dr. Ramakrishna Hanuman, sir. Sir doesn't need any introduction, but it is my duty to introduce sir. Sir, hello. Hello. Sir is a senior gynecologist from Vongol. No, not Vongol, Chirala. He is the most experienced surgeon in the laparoscopy, hysteroscopy, and sir did many live workshops throughout India and presented 500 plus presentations at various conferences, participated as faculty in 30 live endoscopy workshops, organized 7 live workshops at Chirala, presented 240 papers and 30 publications, received Wonder Foxian Award in 2019, Foxy Recognized Center for Endoscopy Training, and trained 100 gynecologists. Welcome, Dr. Hanuman sir. Hanuman sir, are you there?
Hello.
And
Yeah, I'm
Yeah.
there. Good
Okay,
evening,
sir.
all.
Dr. Sudharani. Sudharani is the Associate Professor of Obstetrics and Gynecology from Kurnool Medical. She did her UG and PG from Kurnool Medical College, Kurnool. Presently working as Associate Professor at Government Medical College, Nandyal. She did many presentations and poster presentations in various conferences, and her areas of interest are laparoscopy, infertility, and colposcopy. I think Sudharani is somewhere busy with her mother, as her mother was hospitalized in somewhere else. And the other panelist is Dr. Gayatri Inla. Hello, Dr. Gayatri. Gayatri Inda is the director and lead consultant at Lotus Ultrasound and Fetal Care Center. Her areas of interest are prenatal genetics, pre-eclampsia screening, and fetal interventions. Publications, she had 3 publications and presented at national and international conferences. Welcome, Dr. Gayatri. Gayatri, are you there?
Good evening, ma'am. Yes, ma'am. I'm here,
Gayatri?
ma'am. Good evening, ma'am.
Dr.
Good
Radhalakshmi,
evening, ma'am.
Dr. Tamraveni is there, Dr. Hanuman is there.
I am
Tamraveni
here.
joined, Hanuman
Thank you
joined.
for this.
Yeah, Tamaraveni, you will be the chairperson for this panel discussion. Now I
Yes.
request our moderator, Dr. Patel sir, to say a few words regarding PCPNDT Act. Patel sir.
Yes, I am here.
Yes. Patel sir, you are not on.
Yes, I am here.
Yeah.
Am I audible?
Yeah.
Yeah.
Sir,
Yes.
to
Welcome.
start the session, so the PCPNDT Act is very much important for regularization of the ultrasound, especially in India, for doing ultrasound, prenatal ultrasound for first and especially and second trimester. And the panel will start with the first question will be asked by Dr. A. Sudharani, Associate Professor, KMC Kurnool. Dr. Sudha, your question, please.
Welcome, madam.
You are muted. Sudha, muted. Please unmute. Unmute, Sudha.
Yes, madam.
Good evening, sir.
Good evening.
I thank Dr. Radhalakshmi madam for giving me this opportunity to participate in this platform. Sir, my question is, so what is the genesis of this PCPNDT Act? How it was implemented? Initially it was PNDT, later it became PCPNDT. So how
Yes.
it was, sir? It occurred.
So in census of 1981 and then in 1991, it was observed that sex ratio of 0 to 6 years of children, male to female, was getting deteriorated. So in 1994, PNDT Act was enacted. That is Regulation and Prevention of Misuse of Technique was the main act which was enacted in 1994. But in spite of this act enacted in 1994, again in census of 2001, ratio was further deteriorated. So there was public interest litigation in Supreme Court, and again government came into action and they added preconceptional sex selection in amendment in PNDT Act in 2003. So now it is called PCPNDT Act, Preconceptional Sex Determination, and this PNDT Act, which was old act enacted in 1994. So after 2003, it is called PCPNDT Act. An ultimate goal was to check gender imbalance and regularization of center who are doing ultrasonography in antenatal patient. They should be under supervision of appropriate authority was the main aim of this PCPNDT Act.
Thank you, sir. So our second panelist will. Hello, Dr. Gayatri.
Yes, ma'am. Yes, ma'am.
So please ask your question to Dr. Patel, sir.
Yes, ma'am. Good evening, all. Thank you, Dr. Radha Lakshmi, ma'am, for this opportunity in this panel discussion, ma'am. Sir, why is this PCPNDT Act, sir?
So just I mentioned that it was gender imbalance in and observed in the census of 1981, 1991 and 2001. And that is why this act was enacted in 1994, amendment in 2003, and some further amendment in 2012, 14, etc. But goal was to check gender imbalance and regularization of center. So center cannot function unless it is registered, was the main aim behind this. And either center could be registered in any capacity or any characteristic, I would say. So which type of practice they are having, either counseling or imaging science or simple sonography or genetic clinic, that way. But it should be registered under PCPNDT Act.
Yes, sir. Thank you, sir.
So the other panelist is Dr. Suchitra is not there. So I request Dr. Nagajyoti.
Yes,
Suchitra
ma'am.
is there. Yeah, Suchitra,
Good
please
evening,
ask,
ma'am. Good evening, ma'am.
please ask your question to MC, sir.
Excuse me, Dr.
Thank you,
Radha,
thank you,
madam.
ma'am, for giving
Yes,
this
sir.
opportunity.
Yes, sir.
Sorry for the interruption. I
Yeah.
have an emergency.
Sir, please ask your question, sir. Whatever the question you want to ask MC, sir,
Yeah.
you can ask, sir.
Yeah, can you give me can you bypass madam?
Okay, sir, no problem. You are the senior.
No, it's not the question of seniority. I have an emergency.
Okay, no problem.
Okay, sir, this 18-year-old patient, I know, who's less than 18-year-old persons. A lot of people are coming with pregnancy. And what is the way, and how are we supposed to deal with the PCPNDT Act and doing an ultrasound examination?
So as far as PCPNDT Act is concerned and sonography of antenatal patient is concerned, we have to follow all the provisions of PCPNDT Act. We have to go, first thing, center should be registered, person should be qualified as a sonologist, and then we have to go for filling of the form, etc. But at the same time, when she is 18 or less than 18 and she is having pregnancy, then it becomes a case of POXO also. So at the same time, we have to inform police or member of CWC. We can treat that very patient because many a time, even they are minor, they are interested to continue pregnancy and deliver baby. So we have to counsel them. We have to give antenatal care. And if at all we are going to go for sonography, then we have to observe all the provisions of PCPNDT Act and inform police.
And do we have to send them to government hospital? They are saying that, they
Not
have to have
necessary. Nowhere in PCPNDT or in POXO Act it is written that this type of patient can only be treated at government hospital. Anywhere they can be treated, but just I mentioned, as far as PCPNDT part is concerned, center should be registered. So say for example, I am running private nursing home, my center is registered, I can very well deal with all those cases, but I will have to inform police of jurisdiction where my clinic is there.
Is it mandatory to have a checkup at government hospital and then get back to the private sector for the future follow-up?
No. If and now little deviation from the subject, but if any sexual assault victim is brought to any clinical establishment, so many a time it is interpreted that it should be treated at government hospital only and it should be taken care by only female gynecologist or female doctor only. But say for if it is an emergency, she is heavily bleeding and you have to go for certain surgical intervention, then will you wait for a patient to be shifted to government hospital, or will you wait for any female doctor to come? Naturally, one has to deal with the situation accordingly. And in law, it is very clear that whatever you do in good faith of patient, it is always pardoned. So first you treat the patient and all the legal formalities afterward. In famous case of Parmanand Katara, Supreme Court has mentioned this. Always medical aids prevails legal formalities.
Fine. That's a very good point, sir. And we
Yes.
learned so much. And I'm extremely sorry, sir. I have to attend a meeting.
No issue. It happens.
I'll just try to join you again when I come.
Okay, welcome.
I'll come back and join you, sir.
Oh yes.
Yeah. Dr. Suchitra, your question, please.
Thank you very much, madam, for giving me this opportunity on this platform. Good evening, sir.
Yes, welcome. Good evening.
Which are the major amendments of this act, sir? Can you please enlighten us?
Yes. Just I mentioned in 2003 it was amended and preconceptional sex selection was added. So then also it is called PCPNDT Act. In 2012, then after in 2014, some more amendment came, and one amendment came that one cannot visit more than 2 centers in the same district as a sonologist. So one can give his or her services as a sonologist in 2 centers in one district was the one amendment. One more amendment came during that. If at all you have to go for mobile ultrasonography, then also you will have to inform appropriate authority. Your van should be registered with appropriate authority in which sonography machine is taken for diagnostic purpose, etc. Because in certain states, in hilly area where nearby hospital or sonography facilities are not available, government has granted mobile units having sonography machine, and this type of unit goes to villages and examine patient and do sonography also. But in this situation, that one should be registered as a clinic, and person who is going to go for sonography should be qualified one. So this amendment also came in 2012 or 14. So this type of amendment came. One more amendment came that if any registered person facing any litigation in any court, then they will be rejected, their application will be rejected for renewal of center, or this type of person having any case against him cannot apply for new registration also. This was one more amendment, and there was change in section 18 subsection 3. So in this time, many a times when registration of center is getting expired and person is applying for renewal, but if he is facing any case in any court, appropriate authority rejects their application and denied as far as renewal part is concerned. So these were some amendment in PCPNDT Act.
So,
Thank you, sir.
Dr. Naganjyoti, she is the treasurer of Anantapur OBG Society. Please ask your question to sir.
Thank you, madam. Thank you for giving me this opportunity. Sir, accept my sincere pranamam, sir. My question is, what is the seriousness of this act?
Seriousness of act is very clear. If center is not registered and person is doing sonography, then he will be prosecuted for the same, because doing sonography at unregistered place is a crime. Same way, center is registered, but person is not qualified and doing sonography, then also he will invite litigation against him. So that is the part. And as far as this seriousness, one more seriousness, when in spite of this act, sex ratio, of course, it is improved as compared to past, but it is not that improved which was expected at the time of enacting this act. So government and appropriate authority are very serious about this, that all the formalities of PCPNDT Act should be observed by center and person working at center. Say, for example, filling up the forms as per the case may be. If it is a simple sonography, form F. If it is a counseling, then form D. Then if it is laboratory, then form E. And if it is invasive procedure, then form G. So all these formalities should be observed. And if it is not, then it becomes a difficult one for any person to face litigation. As far as sex determination is concerned, if it is proved that person is involved in either sex determination or preconceptional sex selection or advertisement of this type of facility, then there is a provision of imprisonment of 3 years and fine of rupees 50,000 for first instance, and second time 5 years imprisonment and 1 lakh fine. And not only this, appropriate authority will write to medical council for taking appropriate action, and medical council may suspend registration of medical council, and if it happens, then he is no longer a doctor. So it is a very serious matter as far as sex determination part is concerned.
Thank you, sir.
Yes.
So, Dr. Uma Devi of Tirupati is not there. She is in attending emergency case. Now I ask Dr. Anita Shrikant. She is the professor of OBG from Vishwa Bharati Medical College, to ask her question with Sir, MC Sir.
Good evening, sir.
Yes.
Thank you, ma'am, for giving this opportunity. Sir, my question is, does the onus of all these rules and regulation falls entirely on the doctor, or is the person seeking the ultrasound or genetic counseling, are they punishable under this act, or is it directly entirely on the doctor only?
No, it is very clear. In PCPNDT Act, place is registered, not person. Place is registered, clinic of so and so. And many a time, owner of that clinic is not doctor even. So he will have applied for registration, but at the time of registration, he will give all the information about machines either to be installed or already installed. So with make, model and manufacture, and a list of persons who are going to work as a gynecologist or as a sonologist. So these are the formality. As far as filling up the forms is concerned, is a duty of person who is going to go for sonography. So sonologists who will do sonography will fill up the forms, etc. And being a head of the institution or owner of the institution, his or her responsibility to send those forms in time to appropriate authority at the end of month, within 5 days of next month. And in few of the states, it is online. So within 10 days or within 5 days of sonography done, it should be sent to appropriate authority online. So sending up of the forms is responsibility of owner. If there is any change in employee, change in machine, change in place, change in address, then it is duty of owner to intimate appropriate authority before 30 days that Dr. So-and-so, who was sonologist at our place, now he is not going to come as a sonologist in our hospital. And if any new sonologist is joining, then he has to inform appropriate authority that Dr. So-and-so is joining as sonologist with all the details of doctor, name, address, medical council registration number, and each contact details. But it should be intimated before 30 days of such changes. If anybody leaves institution with immediate effect, say for example, if sonologists say from next day only I am not going to give my services to this center as a sonologist, then in this situation immediately a center has to intimate appropriate authority for such changes.
Sir, actually my question was, the patients and the relatives, they come asking for sex determination. Are they
Yes.
liable for punishment, or
Yes.
is it,
Yes.
or does it fall only on the doctor?
No.
Because they are not aware. Like they will come, in spite of telling
Yes.
them, they will ask us, madam, please
Yes.
tell us, please tell us,
So,
like that.
yeah, got it. So they are also punishable under PCPNDT Act and under section 21. It is very clearly mentioned person seeking aid, and one more section is person giving aids. So giving aids means sonologist or any gynecologist, and seeking aids, that is patient or patient's relative, and there is a provision again for them also, 3 years of imprisonment and fine of rupees 1 lakh for first instance, and imprisonment for 5 years and fine of rupees 5 lakhs for second instance. So they are also liable for punishment. But usually we doctors never inform appropriate authority that so a patient having this detail had been to me for sex determination. I have denied, but you inquire, she may go to another place. But we are not giving information to appropriate authority. Otherwise, they are also liable for punishment under PCPNDT.
Thank you, sir.
Yes.
Because in the news, always the doctors will be highlighted. So that's
Yes.
why I asked this question.
But in Gujarat, we had formed one group of doctors registered under PCPNDT Act, and we had a talk with government. If we gave name of patient or person who is interested to go for sex determination, are you going to take steps? Government was pleased, and for some time we were giving names of patient who were interested to go for sex determination, and government was following those patients, and if at all that patient gets her sex determination done from any other hospital, then those doctors were taken into consideration, and appropriate authority had filed case against those doctors and clinic and those patients also.
Thank you, sir.
Yes.
So next question is by Dr. Divya Teja from Nandyal. She is the assistant professor in Nandyal Medical College.
Good evening, sir. Thank you, ma'am,
Yes,
for
welcome.
giving
Good
this
evening.
opportunity. Sir, I have two doubts, sir. As Hanuman sir has already asked you, if it comes under POCSO Act, we are asked to inform the police. How is it to be informed? Is it to be written, given in a written complaint, or should it be informed on phone? Or is there
Yes,
any
very,
designation of the
very,
police
very
to whom it
simple,
should be informed?
simple dictum. We have to inform police with acknowledgement, because if police doesn't give you any acknowledgement, and in few of the instant it has happened, police may go hostile. You didn't inform, you never inform. So whenever you inform in this type of situation in a POCSO Act, then you have to inform with acknowledgement. So you may inform with letter, you can send 2 letters and get it 1 letter signed. But at the same time, each police station officer are given buckle number. So you can ask for name, buckle number, date and time. If he refuses, many times it happens, they are not interested to sign that very document, then you can inform higher officer also, one thing. Or you can send it by registered post. Same thing, you can send it by registered AD post. It shows your consent that you are interested to obey a provision of law. You can inform, let me complete. You can inform by registered AD. You can inform by mail also. If you have email ID of that police station, then of your jurisdiction, then you can inform on mail also. You can inform on 100 number call because it is recorded call. So whenever you inform on 100 number, but again, word of caution, whom you are informing, you have information. So please ask name, buckle number, date and time, and mention in your case paper that you had informed on 100 number and it is recorded call. So whichever information you have given to number 100, they will pass information to respective police station of jurisdiction of your hospital and proper action will be taken by police. One more thing, in your mobile, if you have facility of recording, then from your mobile also you can inform. But again, you identify the person whom you are informing. And if all this measure you have not or you are not comfortable, you can inform member of CWC, that is Child Welfare Committee. So once you inform member of Child Welfare Committee, it is also enough. Then after, they will take action further as far as to inform police and to take action in this case when there is a case of sexual assault victim.
Sir, until this complete process of informing is completed, shouldn't we do scan for that patient? Should we ask them to wait, sir?
You can very well go with scan, but before your patient leaves your premises, you have to inform. Because many times what happens, say for example, you didn't inform. You have done it, sonography, and you thought that I will inform when my work is over. And many a time it may happen that police may come or appropriate authority may come and they will ask for the details. And if they come to know that patient was minor and you didn't inform, one important question will be asked, why you didn't inform police? So before patient leaves your premises, you have to inform. In any way, just I discussed, you can inform police in any way.
Sir, and what are the common reasons for sealing of the sonography machine or cancellation of the registration?
Many a time, very fake reasons are given for suspension of registration, sealing of the sonography machine, and confiscated some records. So, say for example, some funny mistake in Form F. Name of person is not properly written, address is not properly written, mobile number of patient is not written, doctor has to sign at different places in form at almost 5 places. If he misses to sign at one place or 2 places, then also it becomes a reason to take action from appropriate authority. Indication is not properly written, board is not displayed at conspicuous place. Say for example, under this act, there is a provision that you should have displayed board in your clinic at conspicuous place like this: name of hospital, address of hospital, and writing like this: antenatal sex determination is punishable offense, and this type of sex determination is not done here. And in Gujarat, we have add one line: even to ask for sex determination is also punishable offense, and it is a crime. So this type of board should be there, and if board is not there, then also appropriate authority may go with some action. Same way, registration certificate, that is Form B, it is also to be displayed at conspicuous place. You have to wear apron with name plate, because in one of our Foxy Society in Rajasthan, Ganganagar, almost 18 gynecologists were given notice merely on ground that they were not with name plate at the time of doing sonography. So these are some reasons usually they go for action. But as such, this act was enacted to catch hold doctors who are doing sex determination. So person doing sex determination or advertisement that these facilities are available at their clinic, they are real culprit and they should be taken into consideration for punishment. But merely on this flimsy ground of some inaccuracy in record, appropriate authority may go with action.
Thank you, sir.
Yes.
So the next question will be asked by Dr. Gayatri Indla. She is the fetal medicine specialist in Kurnool. Dr. Gayatri.
Good evening, sir, and good evening to all the other esteemed faculty. Thank you, ma'am, for giving this opportunity. Sir, actually, recently there was a discussion about who is qualified to do a scan. Is an obstetrician qualified to perform a scan? Because there was a discussion saying that obstetrician cannot perform a scan. So what is the provision given in the Act? And there was another clause about radiologist or sonologist practicing is supposed to practice only in 2 centers, can be registered only in 2 centers. So
Yes.
can you some light on
Your
that?
first question, who is sonologist? The same question was asked in one of the case in Supreme Court in 2011. So Supreme Court referred this question to Union Health Ministry and they referred this question to Medical Council. And there was meeting of Medical Council in 2011. I have minutes of that meeting also. And in that very meeting, Medical Council came up with very clear guideline who is sonologist. Any gynecologist having postgraduate degree, diploma, DNB in OBGYN is sonologist. Any teacher of OBGYN working in medical college is sonologist. Any radiologist having postgraduate degree, diploma, DNB is sonologist. Any teacher in department of radiology in medical college is sonologist. Any MBBS doctor who has taken training which is prescribed by government for 100 hours and then after there is exam, and if he has clear examination, then even if he is MBBS, then also he is sonologist. So this type of guideline were given by MCI, and then after in 2012 there was meeting of Central Supervisory Board of PCPNDT Act, and all the observations on part of Medical Council was endorsed by Central Supervisory Board of PCPNDT Act. So all these categories are sonologists and they can do sonography. But as far as gynecologists are concerned, they can do only sonography of antenatal patient. So it was very clear. As far as your second question, what was the second question?
Sir, a sonologist can be registered
Yes.
only with 2 centers.
Yes. So there was amendment in 2012 again, and in that amendment, Central Supervisory Board came with this amendment that person, sonologist, cannot visit more than 2 centers in same district. But this amendment was challenged in different 5 high courts: Hyderabad, Aurangabad, Delhi, and some other 2 high courts. And in all those high court, it was stayed. So at the time of hearing in Delhi High Court was very clear, and he informed central government. Then when there is a stay on this amendment in 4 High Court, and we are also going to give stay in this matter also, till final judgments come, there should not be any harassment to the person who is working in more than 2 places. So till final judgments come, we can visit more than 2 places also.
Okay, sir. Sir, one more question. So there was a mention about the training of MBBS doctors for performing sonography. So how is a center identified? Does the government appropriate authority, they identify a particular center, or can the centers who are interested, they can approach?
So under PCPNDT Act, syllabus is also prescribed, okay, how much lectures and which topics of lectures they are to be taught. And usually it is in medical colleges only. And it is government recognized courses. And you can inquire through appropriate authority. If district appropriate authority cannot give information, then you can write to Central Supervisory Board Delhi. They will give information of colleges where this type of courses are available. And at the end of course, it is a 100 hours course total. And at the end of course, there will be exam. And who clears that exam will be stamped as a sonologist, and certificate will be given by that institution that he has cleared examination. On ground of that certificate, appropriate authority will allow him or her to work as a sonologist.
Thank you very much, sir.
So, Dr. Sudharani, G. Sudharani, are you there? Sudha? Okay. So, the next question will be asked by Dr. A. Sudharani. Unmute. Unmute, Sudha.
Sir, my question is, can appropriate authority can reject the application for registration? So what are the provisions?
Yes. They can reject application for renewal of registration or fresh registration also. But there is a provision that they will have to give reason in writing why they have rejected the application. And there is again prescribed form, that is form C. In that very form C, they will give reason and then only they will reject. But at the same time, there is a provision for doctors also, that in this case of the situation, what is the reason for rejection? And if doctor clears that rejection, then again that application will be considered. And for that, he has not to go for fresh application or to submit fees again. Once he has submitted fees, then it will be considered. He can clarify the query and it will be done. But appropriate authority has power to reject, but he will have to give reason.
Okay. Thank you.
Yes.
Yeah. Dr. Gayatri?
Yes, ma'am. Sir, I have two questions, sir. Sir, if unmarried girl, if she came directly for TIFA scan, sir, is this to be registered in the PCPNDT form, sir?
So any antenatal patient, irrespective of marital status, irrespective of her age,
sir,
if you go for antenatal scan, then you have to observe all the formality of PCPNDT. Center should be registered, person should be qualified. You have to go with form F if it is a simple sonography, or if it is invasive, then form G, and then after you can do sonography.
Yes, sir. Yes, sir. Sir, which are the provisions about renewal of the registration, sir?
So for renewal, usually whenever center is registered, it is registered for 5 years. So before 1 month of expiry, person will have to apply for renewal in the same fashion. That is form A. Prescribed form is form A for registration as well as for renewal of registration with all the details. And it is very simple form. So you have to go with all the details of name of center, address of center, persons working as a sonologist in that very center with their qualification and medical council registration, details of machine. So everything is to be filled and one can apply for registration. And as far as fees is concerned, so if it is a fresh application, then for single entity it is 25,000. And if it is a double entity or corporate, then 35,000. And in case of renewal, fees will be half.
Yes.
So 12,500 or 17,500.
Okay, sir. Thank you, sir.
Dr. Anita, do you want to ask any more question? Anita? You are muted.
Ma'am, can you hear me now?
Yeah,
yes, welcome.
Yeah, sir, I want to ask regarding the maintenance of records, how we are supposed to maintain the records and on what date we have to send our reports to DMHO? What is the procedure for it basically?
Yes. So at the end of month, within 5 days of next month, we are under obligation to send reports to appropriate authority. All the sonography or invasive procedures done at our place. So this is provision for sending the report. As far as preservation of record is concerned, we have to preserve all those records for 2 years. If there is a litigation, then till final disposal of litigation or 2 years, whichever is later, we have to preserve record. If there is a provision to send record online, because there are few states where online registration is compulsory. Say, for example, in our Gujarat, online registration is compulsory. So we have to go for online also within 10 days of sonography done. But in this case, online as well as at the end of month, physical forms are also to be sent to appropriate authority within 5 days.
Okay, sir. Thank you,
Sir,
sir.
sir, my question is, if there
Yes.
is online uploading of this form number F is there, is it necessary to send offline also?
Yes, because because in Gujarat there was case in High Court, and High Court has given a verdict that you will have to go with both the forms, online as well as physical.
So online to be uploaded every day or every 1
No,
week?
no. It differs from state to state. In Gujarat, within 10 days of sonography done. In some other state, it is within 5 days. So whichever the guideline from that respective state where you are working, you have to follow the instruction.
Okay, sir. Okay. So, Dr. Divya Teja, do you want to ask any question?
Sir, what is the declaration on the part of the patient and the doctor, and what has to be written?
So it is very much mandatory as far as declaration is concerned. And in Form F, it is in section D. There are some section A, B, C, D. So D is for declaration. Declaration on part of patient that she is not interested to know sex of her baby with this sonography. So this type of declaration she will give. But she will give this type of declaration before sonography. And after sonography, doctor will give declaration who has done sonography that during sonography, I have neither seen nor declared sex of baby to the patient. And it is very much mandatory. If doctor is giving separate report of sonography done, then at the end of report, same kind of declaration he has to sign. Under Rule 10, Subrule 1, Subrule A, it is very much mandatory to go with declaration at the end of report also.
Yeah, Dr. Tamravani, do you want to ask any question? Hello, unmute Tamravani. Unmute.
Hello.
Yeah.
Yes, welcome, madam.
Thank you, sir. Thank you so much. Welcome, sir. And hearty congratulations before your election, sir. Definitely,
you,
will
ma'am.
win, sir. We are here to support you before
Thank
for
you,
Radha
madam.
Lakshmi, madam.
Thank you.
And my question is only one, sir. Because a patient, sir, you told already, if it is a below 18 years girl comes to the hospital, unmarried, below 18 years, you said actually when the patient in the hospital, within that time only we have to inform the police. If the patient get admitted in the hospital, shall I inform the after 1 day or 2 days?
Will do, because patient is with you. And but in this situation also, there is a very clear-cut guideline. Whenever you are free of your emergency,
yes,
and you are able to send report to the police, then you have to inform or appropriate authority.
Okay, sir. Thank you so much, sir.
Sir, I have a question, sir.
Yes.
Sir, regarding the PC-PNDT panel, who is there in the board, and can they visit the center anytime without informing us for inspection? Like, what are the...
No, there are two separate category: appropriate authority or sub-district appropriate authority. They are designated for the same, and they are delegated with power to visit center, inspect record, and give you notice, etc. But there is one own board having one gynecologist, one pediatrician, one sonologist, and government may invite 2, 3, 4 more people from private sector also. This is supervisory board, district supervisory board, state supervisory board, and central supervisory board. They have no power to inspect any institution unless they are delegated power by appropriate authority to visit that very center. By law, they are not authorized to visit. But many times it happens that any person from that board, appropriate authority may delegate power to him to inspect. Then he can or she can inspect.
Thank you, sir.
So Gayatri, Inla, are you there? Okay.
Sir, what is that appropriate authority, sir? Who will decide that?
Appropriate authority will be decided by government. As far as central part is concerned, central appropriate authority will be decided by central government, and state government will decide state appropriate authority and district appropriate authority. And in union territory, central government will decide appropriate authority, and it will be published in government gazette that Dr. So-and-so is appointed as an appropriate authority of this district in this state. So this type of order is given to that appropriate authority, and then after they can take charge as far as PCPNDT Act's provisions are concerned.
So
Another question, sir.
Yeah.
Like
You have to ask.
a minor gets a checkup done at GGH, and she comes for a scan to us. Like if they had a checkup in GGH, she will have been given RCH ID also. Should we inform the police if they come to us?
So any minor comes to you and you came to know that she is victim of sexual assault. So if she is pregnant, so naturally she is victim of sexual assault. It is considered by law. So you are under obligation to inform police under section 19 of POCSO Act. So you have to inform. And if you fail to inform, then again there is a provision in section 21 of POCSO Act, and there is a provision of 6 months of imprisonment and fine or both. So once you come to know she is minor, she is victim of sexual assault, then you have to inform. I will give one more example. 16 years old girl is brought to you by her mother with complaint of itching vulva and discharge per vagina. On your examination, she is found to be a case of sexually transmitted disease. She is not pregnant, but she is found to be a case of sexually transmitted disease. On further interrogation, when you ask patient reveals history of exposure to her boyfriend. So it becomes a case of POCSO. Of course, you have to treat that very patient, but you have to inform police.
Thank you, sir.
So one last question by me, sir. So if there is most of the scan companies, they take the mission buyback, sir. In such cases, what are the precautions or what are the things to be informed to the appropriate authorities?
Yes.
So
So whenever
done by most of
because your machine is already registered with that very place which is registered under PCPNDT Act. And when you are giving that machine buyback to company, or you are selling that very machine to any registered center, in both the condition, you will have to inform appropriate authority. An appropriate authority will permit, and then only machine can be taken by either company or you can sell it to any other registered center. But in this case, if at all you are going to sell that very machine, then it can be only sold to registered center only. You cannot sell machine to unregistered place or unauthorized person. So this is very clear. The same way, when you buy any machine, then also you will have to intimate appropriate authority before 30 days with details of that very machine, make, model, and number of that machine. And after installation of that machine, again you will inform that machine is installed and I am going to start work on that machine from this
No,
date.
sir, what my question is, so we are selling back that mission to the pharma, company.
Yes,
people.
yes.
We are getting the new mission. Will get the same number or will get a new number for that mission, sir?
No. Machine number is given by company only. And
no,
different
sir.
machine have
Center number will
separate
be the
number.
same.
No. Just like any vehicle chassis number. Same way in sonography machine also.
Yes, sir.
Each and every sonography machine has their own number. So make of that machine, model of that machine, and number of machine, that means that hardware inside the machine is given number. So that is number. So we will have to inform appropriate authority with that details, that we are giving that machine buyback to company, and appropriate authority will allow us to give it to buyback to company.
And will be having the same number only. Registration number will be the same.
I couldn't follow you.
No, sir. Registration, we will be getting one registration number when we had
Once your center is registered
Yes.
and number is given, number will not be changed.
Okay, sir.
Unless you surrender certificate and ask for new registration, then party is a different story. But registration number will be the same. When you giving machine buyback to company and you have no machine, then in this situation you will surrender your registration
Number.
certificate to appropriate authority. And once you buy new machine,
Along
then
with
same
the
registration number will be given back to you.
if
Registration
you
number
buy
will be
one
same.
more mission, it will be added as like add-on mission only, no, sir?
Yes, but if you are having more than one machine, say for example, you are having two machines, and if you are giving one machine buyback to company, no need to surrender registration to appropriate authority, because in that very registration, your second machine is already there. It is mentioned. So you can have that registration and you can buy one more machine. Even you can buy n number of machine, I would say.
Okay, you
If
can
we are
buy.
taking buyback, sir, if we are
one
taking a
question.
new machine, do we have to pay the registration amount again?
No.
If it is there within that renewal period.
Under Rule 13, it is very clearly mentioned. It is only intimation. Intimation to appropriate authority about change of machine, change of employee, change of place, change of address.
Sir, one
It is
question.
Last question,
intimation.
sir. Last question.
Sir.
Radha Lakshmi,
welcome.
this is only last question.
Okay,
Sir,
okay.
one doctor should run only one mission or many missions when?
No. One, say for example, if my place is registered, I
Yes.
can have n number of machine.
The same number.
Registration number will be the same. Because here place is registered. Machine is not registered. Machines are mentioned in that
Doctor
very
can work
registration.
only in two places. The
Two
doctor
places.
can two places.
And one more thing.
Yeah.
And in one center, n number of sonologists can also work. There is
Acha.
no limit. Say for example, if my hospital is big one, if I
Yes.
have 10 machines, I can invite 10, 15 sonologists at my place. And registration number will be the same. Registration fee will be the same. No further fees, no further registration number. Because place is registered and all the details of sonologist or all the details of sonography machine will be there with that very center only.
Sure.
Sir, one question.
Yes.
Sir, if married teenage pregnant woman, if there is a need to inform to police, sir, because in
Yes.
our general hospital we are getting so many teenage
No.
pregnant women, married one, and
Madam,
is there
in
need
POXO
to
Act,
inform?
in POXO Act it is very clear. Age matters. Marital status doesn't.
Yes.
So even if she is married, but if she is less than 18, you have to inform.
Okay. Sir, only with their willingness we have to inform, because
No,
they are mostly they are not
willingness
willing
on
to.
part of
They
patient
don't.
or relative is not required. Because in usual course, they will deny. They will refuse. They will request even you.
But most
please
of
do
the
not
times
inform
what
police.
happens is if we inform police, patients start quarreling with us.
Yes, sir.
Of
Same
course,
thing
yes.
happening.
I know this is social hazard. But
Even they may
Hmm.
attack us physically also. Sometimes in
it happens.
private
It
hospitals.
happens. But in all this situation, you can inform police again if they are quarreling or they are attacking. But if we do not inform, and if at all they file complaint against that very boy, then police will come to you. When you
So
came to
if
why
we
you didn't
want to
inform?
inform them, they must give their correct address, sir. So when we
Aadhaar
ask
card.
for Aadhaar card or correct address, they don't tell how to
yes,
inform, sir.
in this situation, when patient is minor, always ask for any ID proof.
So if
These
they
are
are not
Aadhaar card,
giving proof or
school
address proof,
living, any ID proof.
sir, if they are not giving, sir, it
I am
happens
coming
many
to
times.
that. I am coming to that. School
Send to
living
forensic people.
certificate, election card, Aadhaar card, any
Sir, they
ID
won't
proof.
give
you trust.
anything.
If they do not ready to give, and if you have come to know that she is pregnant and she is minor, you have to inform.
Sir, they are not informed. They are not giving any details of their address or their identity. How to inform about that patient or that girl to the police people.
Madam,
And
on
they
admission,
don't even,
their address
they
will be
don't
there in
even
case
allow us to take the photo also.
But at the time of registration of their case,
admission they'll be there.
a registration counter, will they give them?
It happens in government hospitals, but in
Sir, the
private.
patient,
Even
the
in private
police
also.
also exploit, sir. Exploit the case, police.
Private also. And
not-
if this type of things happens, then also you can inform police. Some patient came to me, she is not ready to give her name, age, address, but it seems to be minor, and I am doubt. Please inquire. So once you inform, it shows your consent that you are helping provision of act.
Sir, in such case, who are punishable, sir? Is it parents or husbands who are punishable in such case?
Naturally, yes, husband if she is minor. But in one of the cases in Supreme Court recently, Supreme Court has a very good observation. When they are happily enjoying their marriage life more than 1 year, and even if they are minor, and if doctor has failed to inform police, lenient view should be taken against doctor and doctor should not be punished, was the observation. But till this judgment comes and with interpretation word to word, we have to stick to provision of act itself, because there are two types of law: statutory laws, which are enacted in Lok Sabha, Raj Sabha, and then it is published in government gazette. They are statutory laws. And there are case laws. During deciding any case, Supreme Court or High Court goes with certain observation, certain guidelines, and they become precedent and case laws for case in future. But when there is a conflict between case law and statutory law, then naturally statutory law always prevails.
Okay, sir. Thank you.
So, thank you, sir. We will conclude the session. So it is a lengthy session. Thank you very much, sir. Wish you all the best. And I thank
So
Dr.
it is my humble appeal to endorse my candidature for post of President Foxy for year 2026. And please vote and canvass for me. Election would be from 1st August to 10 August.
Yes.
Sure, sure.
So, and I am quite hopeful. Whole Andhra
And
Pradesh.
election result will come by the evening of August 10th.
5 p.m. 5 p.m. End of the election, and 6 p.m. will be result after 1 hour.
So thank you, Sir Patel, sir, for your involvement in this great webinar. And thank you, Dr. Monica Umarban, Dr. Monica Gupta, and Deepika is there, and Shatabdi, and Gupta, and Nivedita. And thank you very much, our chief guest, Dr. Sheshasai, sir, Parthasarathi Reddy, Dr. Padmalata and Aruna Rao, and our chairpersons, Dr. Venkatramana, sir. Venkatramana, sir, thank you. And Dr. Padmaja, Savitri, Pendekanti Padmaja is there. Thank you, Padmaja. Thank you, Savitri. and our first speaker, Dr. Uma Devi, and the second session chairpersons, Dr. Pramoda, Dr. Tamarveni, Dr. Nagamani. So Tamarveni, thank you for being with us till the end. Our second speaker, Dr. Sridevi Anumala, and the third session chairpersons, Dr. Usha Rani, Dr. Manikya Rao, Dr. Sharada, and our lovely speaker, Dr. Sujay Sri from Bhimavaram. You are fantastic. And our panelists, Dr. Sudharani A. and Dr. Gayatri Vaishnavi, Dr. Suchitra, Dr. Nagajyoti, Dr. Baby Shalini, she is in duty. Dr. Uma Devi Ralla, she is also in duty. Dr. Anita Shrikant, Dr. Divya Teja, Dr. Ramakrishna Hanuman sir, Dr. G. Sudharani, she is ended in the emergency. And Dr. Gayatri Inla. Thank you very much. Thank you one and all. I request all of you to support Dr. MC Patel sir. I am also contesting for the post of Ethics and Medical Legal Committee chairpersons. I request the support from Dr. MC Patel sir from Gujarat and all the Northeast, North, South, East and West, Dr. Deepika.
So,
and I request you all to.
This is my humble appeal and request on my part also to support candidature of Dr. Radha Lakshmi, and she is going to follow me because long back in 2011 I was chairperson of Ethics and Medical Legal Committee Foxy, and if she follows me, I will be the happiest person. So my all the good wishes to Radha Lakshmi for her election also.
Hello. Radha Lakshmi ma'am.
Yeah, Tamarveni.
Yes. I want to say, sir, one
Hanuman
second.
sir.
I'm back.
Sir.
Yes.
Hanuman sir, please support from Vongol, from entire Vongol to MC Patel sir.
Sure. Sir is always my well-wisher, and he always involves me in his business.
Hanuman is close friend of mine since long, and he will be with me always.
Dr. Sujay Shri, do you want to tell anything?
Sure, ma'am.
Hello.
Previously also,
So before
all the best
we
to
conclude,
Radha Lakshmi madam and Patel sir, and we'll definitely support you, sir.
So before we conclude, there is one question in chat box. After female feticide case ended in maternal mortality, when a decoy operation done to bring out facts, the center showed the US machine in condemned state. When can they condemn the machine? So in this type of situation, whenever your machine is totally out of order and it is not repairable and you have to condemn, then also you will have to inform appropriate authority himself or herself or any representative delegated by him or her will come to your hospital, and before them only that machine can be demolished or condemned. Otherwise, you cannot do like this and it becomes a punishable offense again. So be careful in this type of situation. If your machine is totally out of order, not repairable, then also you have to inform appropriate authority.
Okay. Dr. Radha Lakshmi ma'am.
Yeah.
I want to say something, sir. Sir, please, we are with you, sir. We are definitely voting you, sir. But you should, our daring, and our lovable Secretary of Coxy Karnool, Dr. Radha Lakshmi ma'am. Please support her, sir. She is a very and dashing madam.
I am already supporting her, and I had supported her in past also.
Yes, sir. Now also, please, sir. She should win. That's it. You and she. We know
Sir,
you.
Not only support,
question, sir.
Madam,
Most of the time, sir, the sex detection is done by other sonologists, and they come for termination of the pregnancy, telling some silly reason. What should we do, sir, as a gynecologist?
Madam, I couldn't follow you.
Sir, most of the times the sex determination was done by some other gynecologist, and they approach us as a obstetrician and they want a termination of pregnancy, telling some silly reason like failure of
Got it. So in this type of situation, we should be very careful. And which is the vulnerable gestational age? 11 to 13 weeks or 14 weeks or maximum 16 weeks. And in this type of situation, when patient comes for termination of pregnancy, first, what is the indication of termination of pregnancy? We have to inquire. And one more thing, inquire about her obstetric history. If she is having one female child, if she is having more than one female children, then these are the vulnerable group of patients that likely they might have gone to some other place for sex determination and they have come with selective feticide, I would say. So in this situation, always better to not to entertain this type of.
Sir, one more last question, sir, please. This is about the MTP Act, sir. If the MTP Act certificate should get every medical college, sir, from the DMHO or the institutions like private medical colleges, they should get any.
As far as MTP Act's registration certificate is concerned, previously it was given by government, state government in respective place.
Yes, yes.
And then after in 2003, there was again amendment and district level committee was formed. So in each district, there is a district level committee. Now that district level committee inspect center and they issue certificate of registration. And for that appropriate authority is Chief District Medical Officer.
Yes.
In different state name could be another. But he is not the same person who is looking after PCPNDT. PCPNDT appropriate authority and appropriate authority for MTP Act are different.
Yes.
So that authority is authorized to certify any center for MTP center. So you have to apply to that CDMO and they will put all these application before district level committee. District level committee will verify the documents and they will have an inspection, personal inspection to that very clinic. And if they are satisfied with all the gadgets, then they will give certificate.
So all the medical colleges, sir, government medical colleges and private medical colleges also should take.
This is for private medical private clinics.
Medical colleges.
So I will be sharing the number of Dr. Patel sir in the group Tamaravani as it is already 9:30.
Okay, okay.
Okay, you can ask anything.
Contact him directly.
Okay, okay.
So I am having sir's number and sir mail ID. I will share the group and I will share the sir flyer also for the election purpose. In all the proxy groups of Kurnool, I request all the presidents and secretaries to spread the flyers in your respective groups and support MC Patel sir. Thank you very much, sir. Thank you, sir.
All the best, Radha ma'am. Very well conducted. Thank you, sir.
Thank you, sir.
Thank you,
Deepika,
everybody, for
do you want to
everything.
tell anything? Deepika?
No, I just wanted to say thank you very much, ma'am. So
you.
well conducted, this webinar. And thank you, sir, for the opportunity. And best of luck to both of you, sir.
Thank you.
And
Thank
ma'am.
you.
Sir. Thank you, sir.
Thank you, sir. Thank you, ma'am.
Thank you, sir.
Sir, thank you, ma'am. Good night, ma'am.
Good night.
Thank you, sir. Thank you, sir. Thank you.
So,
Thank you.
Nilesh, we can
Yes,
conclude.
sir. Thank you so much, all the respected delegates and faculty members present over here. We have successfully conducted 216th edition with MC Patel sir, Happy Learning Masterclass edition, and looking forward to support such a valuable and insightful webinar in future also.